Hello. Check, check, check. Can you hear me, sir? Hello. Your mic is muted.
Okay, right now?
Yes, sir. Good morning.
Good morning.
Okay, sir.
Can you hear me?
Yes, yes. Well,
Okay, fine.
sir, 1 second, sir. I will share your screen. I'll show you. Right, sir. This is your slides.
Yeah,
Okay.
yes.
The first 2 minutes it will be running automatically, sir.
Okay,
And after that, the 3 minutes they will be asking questions and you can
okay.
answer. So the first 2 minutes, no audio, only the
Hmm.
slides will be running around like this. Every slide has a 20-second rollover.
Okay, fine.
Okay, sir. So you're okay with that? You want to ask anything?
Your voice is not clear.
Hello.
Right now, okay.
You're clear about that, sir? You want to
Yes.
ask anything?
No problem.
Okay, sir. So you can log out now.
Okay.
Before your talk, you can 15 minutes prior you can log in, sir. 8:30 it's
Okay, fine.
starting. 8:15 you
I
log
I
in,
will
okay?
log in by 8:15.
Yes, sir. Yes. Okay. Thank you
Thank
very
you.
much.
Silpi madam, can you kindly unmute yourself? Check. நான் பேசுறீங்க வருது வரக்கூடாது இல்ல check இது வழியா
Yeah,
வருது good morning Selfie ma'am.
yeah, good morning, sir.
You can unmute your video while your thing.
Okay, sir.
We will run your slides like this. It will
Okay,
go automatically. The judges will see this. After
Mm-hmm.
2 minutes, they will ask you the questions for three
Okay. Yes,
minutes.
sir.
The timer will run for you like this. You
Okay.
seeing the timer, no? They will ask the questions.
Okay.
That's
Okay,
all.
sir.
That is the procedure.
Okay, sir.
Uh, you log in 15 minutes prior and be as a attendee. We will make you as a panelist like this.
Okay. Okay, sir.
That's all, ma'am. Thank you.
Thank you. Yeah.
Hello. Check, check. Mr. Good. Hello. I'm not able to hear you. Kindly unmute yourself and speak, please. And rename yourself or your name, please. I'm not able to hear you. அந்த லேப்டாப் ஆடியோ ஓப்பன்ல இருக்கா? அதை செக் பண்ணி பாரு ஆடியோ வருதானே? Kindly keep speaking good. Keep speaking. If you are speaking, I'm not able to hear you.
Yeah, yeah. Can you hear me now?
Yep. Sir, your good name, sir?
Logesh.
You are in the e-poster session, sir?
Yeah, 9:15 to 9:20.
Yeah. Now, what you are seeing is a e-poster thing. It will come like each slide 20 seconds.
Okay,
After that finish, no, they will ask you the question. The moderator will take over. They will
okay,
ask you the question. During that time, you will unmute your video and audio and talk to them.
sure.
That's also. Thank you. I will make you attendee again.
Yeah, yeah.
Thank you, sir.
Thanks.
Sir, 15 minutes prayer. Be there, sir.
Yeah, sure, sure, sure.
Thank you, sir. Dr. Pranav Sinde, இங்க இருக்காருப்பா. Unmute yourself and talk to us, please. Pranav, sir. Pranav, sir. Hello.
Hello. Hello, Dr. Krishna Prasad. Can you unmute yourself?
I've unmuted myself.
Yeah, one thing. I'll cut the phone.
Oh,
I'll come to you.
okay.
Hello. Good morning, sir. Can you please unmute yourself and speak? Hello.
Can my slides be displayed?
Hello. Check, check. Can you hear me, sir? Check, check. Check, check, check. Hello. Hello, Dr. Krishna Prasad. Can you hear us? Check, check, check. Can you hear me, sir? Hello. Full da. Full. Check, check. Hello. Hello. Hello, doctor.
Hello?
Hello.
Yeah.
You can't hear us, sir.
You cannot hear me. I cannot hear you. Okay.
The laptop.
Yes.
It's okay now.
Check, check. Can you hear me now?
I can hear you now.
Okay.
Hello?
Yes, sir.
What
So,
do I do now?
one second, sir. So,
Yeah,
this will
these are
be,
my slides.
yes, sir. The first 2 seconds it will be auto run.
Do I have to say anything or they just display it?
Yeah, it will be displayed. The 2 minutes you have to keep your mic muted. Once your slide is finished, the judge will ask you questions. Then you can unmute yourself and answer.
No, I don't have to answer anything, right? I don't have to tell about my slides, right?
Yeah, no need to tell anything.
check. Talking from hall. Narmada. Talking from hall Narmada. ஓகேவா ஓகேவா வாக்கி டாக்கியில் சொல்லுங்கம்மா. மயிலு கேட்குதா மயிலு? செக் செக் பேசிட்டு இருக்கேன் சுரேஷ். மியூசிக் ஜாஸ்தி வருமா? இப்போ நான் பேசுறது கேட்குதா சுரேஷ்? செக் ஒரு நிமிஷம். செக் செக் ஓகே நீங்கள் பேசுங்க. சுரேஷ் சுரேஷ் இதில் பேசுங்க சுரேஷ், உங்கள் மைக்கில் பேசுங்க சுரேஷ்.
Check, check.
ஓகே
Check.
ஓகே
Right. ஓகேங்கண்ணா.
செக் அண்ணா, செக் செக். மயில்ண்ணா இது ஓகேவான்னு சொல்லுங்க. என்ன பேச முடியாது, பேசுங்க.
ஆ நஜு,
மயில்ண்ணா இது ஓகே.
ஓகே நஜு.
ஜாஸ்தி எதுவும் இல்லை, ஜார் ஆகிற மாதிரி எதுவும் இல்லை.
இல்லை ஆடியோ போட்டிருந்தீங்கல்ல,
ஆமாங்கண்ணா.
இங்கே பயங்கரமாக ஜார் ஆகிட்டு இருந்தது, அதான் கம்மி பண்ண சொன்னேன்.
ஒரே நிமிஷம் நான் அதையே போடுறேன்.
ஆ
அப்படியே மைக்லேயே சொல்லுங்கள் ஜார் ஆகுது என்னென்னு.
ஆ
பாருங்க, ஜார் ஆகுதா?
ஆக்ஸ் மட்டும் கம்மி பண்ண, ஆடியோட
கம்மி பண்ணியிருக்கேன், பாருங்க.
ரொம்ப கம்மியாயிருச்சு. ஆ ரைட், ஓகே ஓகே, இன்னும் கொஞ்சம் கம்மி பண்ணிக்கோ. ஓகே நஜு.
Silacar, India's #1 CCB in management of hypertension. Myotan CM. Bisotan. Silacar, India's #1 CCB in management of hypertension. Myotan CM. Silacar, India's #1 CCB in management of hypertension. Myotan CM.
check, 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 check. Check, 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 check. Check, 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 check.
Sulfika.
Sir, good morning, sir. This is from Ahmedabad.
Anand,
Anand. This is Dr. Suresh Kumar. I can see Dr. Sulfikar.
Yes, sir. You have to
Suresh
switch
sir,
on your
I
video,
can
sir. 1 second, sir. I
I
will
cannot
request
see
you.
you. You are
You can't
invisible.
see me. Oh, I see. My video has not been started.
Okay,
My
that's okay.
fault.
Because I was
Sulfika.
wondering, the sounds look so familiar. അപ്പം
Sir, good morning, sir.
സാറും
This is
ഞാനും
from
ബലദ്വാണോ?
Ahmedabad.
ആനന്ദ്
ഭാരതിനെ റീപ്ലേസ് ചെയ്താണ് ഞാൻ. Anand.
ഓ അത് ശരി.
This is Dr. Suresh Kumar. I can see Dr. Sulfikar.
Yes, sir. You have to
Suresh
switch
sir,
on your
I can
video, sir. 1 second, sir. I
I
will
cannot
request
see
you.
you. You are
You can't
invisible.
see me. Oh, I see. My video has not been started.
Okay,
My
that's
fault.
no, your video is seen. Now your scenes look so familiar. അപ്പം
Sir, good morning,
സാറും
sir.
I find
ഞാനും
Anand's
ബലദ്വാണോ?
picture covered by a Clopitab advertisement. ഭാരതിനെ റീപ്ലേസ് ചെയ്താണ് ഞാൻ. Anand.
ഓ അത് ശരി.
This is Dr. Suresh Kumar. I can see Dr. Sulfikar.
Yes, sir. You have to switch on your
I can
video,
see.
It's nice to see you also. Instead of the Clopitab ad. Sulfikar, are you in Trivandrum or did you actually go to Ahmedabad?
No, not exactly. You won't catch me catching a flight to. Even my son did not go. I think he was pressurized by his family, including me, not to go.
Not to go.
So you are.
I'm in Kottayam.
Kottayam only. Okay.
Kottayam.
നർമ്മദ എന്നുള്ള ഇതാണ് ശരിക്കുള്ള നെയിം തോന്നുന്നല്ലേ? ഡി അല്ല, നർമ്മദ.
അതെ അതെ, ഇന്ത്യയുടെ ഏത് ഭാഗത്ത് നിന്ന് എഴുതുന്നു എന്നുള്ള അനുസരിച്ചിരിക്കും.
നോർത്തില് ട്രിവാൻഡ്രം വിൽ ബി ട്രിവാൻഡ്രം.
അതെ അതെ അതെ.
Sir, good morning, sir. Sir,
Yeah, good morning.
the plan is for the slide show, we will run 20 seconds each slide.
Okay.
Each presenter got 6 slides. So 2 minutes automatically it will run. The presenter will be available for the question answer. 3 minutes for question answer, sir.
So the slides will come automatically.
Automatically.
We can ask questions to the presenter for 2 minutes.
3 minutes, sir.
3 minutes, okay.
Yeah. 2 minutes presentation, 3 minutes.
And 3 minutes discussion.
No talk during the presentation.
Yeah. സുഫിക്കർ വേറെ എന്തെങ്കിലും ഉണ്ടായിരുന്നോ ഇതുവരെ?
സാർ ഒരു പീഡിയാട്രിക് സെഷൻ ഉണ്ടായിരുന്നു, ഒരു കസേര ചെയർ എന്നുള്ള ഒരു അവസ്ഥയായിരുന്നു.
So you're familiar with the system?
More or less. Because I was guided through this system very, the discomfort you feel. I think we are.
I know.
Uncomfortable than the presenter perhaps.
Yeah.
കോശി എൻ്റർ ചെയ്യാൻ നോക്കി. ഇപ്പം നിങ്ങൾ ഇവിടുത്തെ ആളല്ല എന്ന് പറഞ്ഞ് പിരിച്ചു വിട്ടു എന്നാണ്
പറഞ്ഞത്. ഇതില് ചെന്നൈയിൽ എന്റെ റെസിഡന്റ് ആയിരുന്ന ഒരു കുട്ടി ഉപയോഗിക്കാറുള്ള ഒരു ടേം ഉണ്ട്, ദ ടെക്നോളജിക്കലി ചലഞ്ച്ഡ് ജനറേഷൻ.
ഞാൻ ഉപയോഗിക്കുന്ന
അപ്പൊ നമ്മൾ അതിനകത്ത് തീർച്ചയായിട്ടും പെടുന്നു. പിന്നെ ഇതൊക്കെ മാനേജ് ചെയ്യുന്നത് വലിയൊരു നേട്ടമാണ്.
They find it sometimes difficult because when we started, Koshi and I together, but Koshi മുമ്പിലോട്ട് പോയി ഈ കമ്പ്യൂട്ടറിൽ.
But I must confess, in the post-COVID era, ഈ വെബിനാർസിന്റെ ഫ്രീക്വൻസി വന്നതോടുകൂടി നമുക്ക് കമ്പൽസറി ആയിട്ട് കുറച്ച് അപ്ഡേഷൻ ഉണ്ടായിട്ടുണ്ട്
വേണ്ടി വരുന്നു
അതില് ജീവിക്കുന്നതിന് വേണ്ടിയിട്ട്.
അപ്പം ഞാൻ ഒരു ഉഭയജീവിയാണല്ലോ, അതായത് CSI പിന്നെ കാർഡിയോളജിയിലും ആളാണ്, പീഡിയാട്രിക്സിലും ആളായതുകൊണ്ട് നമ്മുടെ വെബിനാറിന്റെ നമ്പർ വിൽ ബി
മച്ച് മോർ. ഐ നോ.
Karthik is the first presentation.
ടൈം ഉണ്ട് പക്ഷേ ഇനിയല്ലേ. സുൽഫിക്കർ ഹോസ്പിറ്റൽ റെഗുലർ ആയിട്ട് പോകുന്നുണ്ടോ ഇപ്പൊ?
സാർ കിംസിലാണ് ഞാൻ ജോയിൻ ചെയ്തത്.
ആണോ? I know. You go daily?
Not daily, sir. 3 days a week. പണ്ട് മുതലേ.
ശരി. ബാക്കി ദിവസങ്ങളിൽ വെറുതെ ഇരിക്കുന്നു.
ബാക്കി ദിവസങ്ങൾ ഒരു ദിവസം അവിടെ ഒരു ചൈൽഡ് ഡെവലപ്മെന്റ് സെന്റർ എന്നൊരു സാധനമുണ്ട് സാർ. SIGയുടെ ഭാഗത്തുണ്ട്. അവിടെ കുറച്ച് കാർഡിയോളജി റിസർച്ച് എന്ന ഒരു അഭ്യാസം. പിന്നെ പുഷ്പഗിരി പോകുമായിരുന്നു. അപ്പം
കോവിഡ് വന്നപ്പോൾ നിർത്തിയായിരിക്കും അല്ലേ?
നിർത്തിയായിരുന്നു. പുഷ്പഗിരി ഇവൻ അതർവൈസ് തിരുവല്ല ഞാൻ പോകും, കാരണം മോനോടെ ഉള്ളതുകൊണ്ട്. ഗ്രാൻഡ് സൺ ഒക്കെ ഉള്ളതുകൊണ്ട്.
അതെ.
Karthik, you are ready to go.
Sir, yes, sir.
Okay.
നേരത്തെ തുടങ്ങിക്കൂടെ? അപ്പം ഇവരോട് ഈ ആനന്ദിനോടും ചോദിച്ച്.
സമയമായി.
Sir, we are also ready.
8:30
is starting time.
Yes, sir.
Okay.
And we'll ask Cochin Studio to start with this.
ഇന്നലെ ആരോ സമയത്തിന് 1 മിനിറ്റ് മുമ്പേ വോട്ട് ചെയ്തു എന്നൊരു കംപ്ലൈന്റ് ഉണ്ടായിരുന്നേ.
അതുപോലെ
എന്ന് പറയുന്നത് നമ്മള്
സമയത്തിന് മുമ്പിൽ തുടങ്ങിയെന്ന് വേണ്ട.
അതെ അതെ.
പക്ഷേ ദിസ് സിസ്റ്റം മസ്റ്റ് ബി വെരി ഗുഡ്, ബിക്കോസ് വലിയ ആർക്കും ബുദ്ധിമുട്ടില്ലാതെ ഇത് കൊണ്ടുപോവുകയാണ് അവർ.
Certainly, I am quite impressed.
Very, very much impressed. മൈനർ ഹിക്കപ്പ് ഉണ്ടെന്നേ ഉള്ളൂ, പക്ഷെ അതർവൈസ് ഗ്രേറ്റ്. ബിക്കോസ് ഞാൻ നേരത്തെ സാർ പറഞ്ഞ പോലെ ടെക്നോളജിക്കലി ചലഞ്ചായ എന്നെ വരെ സ്റ്റിയർ ചെയ്ത് ദ റൈറ്റ് ഹാൾ, ദ റൈറ്റ് പ്ലേസ്, റൈറ്റ് ടൈം എത്തിക്കാന്ന് പറയുമ്പോൾ
തീർച്ചയായിട്ടും വലിയൊരു നേട്ടമാണ്. And they were daring enough to go ahead with organizing the conference.
Exactly.
And carry it through quite well.
Quite well. ഇനിയിപ്പോൾ ചിലപ്പോൾ ടുമോറോസ് kind of scientific activities will be to some extent will be influenced by this webinar.
Yes.
Definitely.
No, naturally this question comes, if it is possible to do it from where you are working, why should you travel to the other end of the state, or other end of the country, or other than, of course, it is nice to meet friends in person.
That's one factor that is.
Yes.
Maybe what you call as the specialized CMEs can be done by webinar, whereas the major meetings can be in physical.
Yes, in-person meeting is the current terminology.
I see. That is that, in person.
See, in the post-COVID era, it is not only that technology, but terminologies are also evolving.
Webinar. Zoom.
Yes.
I will zoom you.
Yeah. Somebody had said that if Shakespeare was born today, he will not understand half the words in English.
Especially WhatsApp English.
Yeah. I suppose even the Oxford English Dictionary,
has
quite a few words have been added in the. Yeah.
Exactly. Karthik, you can relax because the slides will talk for you.
Yes.
Okay, sir.
Okay.
Sir, 8:29. Shall we start, sir? You
Yeah.
formally start.
If you're ready, we can start.
Yeah, you can formally start.
If
And,
time is okay. I'm just curious, is there anybody other than Karthik listening to this?
sir, all the next speaker and all will be there in the attendee position.
Oh, okay. So and they can hear?
They can hear, sir. Whatever proceeding is going on, they can view and hear. Sir.
Oh, there are 13 participants. I see that.
13,
Yeah.
13 participants.
Okay.
Sir, we can start, sir.
Yeah.
Sir, can I start the first?
Please, please.
Sir,
Karthik, yeah, I'll ask you a question. Karthik, you have said that this patient should have been operated in the neonatal period, at least in early infancy. Is that your understanding about tetralogy or a tetralogy-like presentation of DORV repair?
Yes, sir.
I must tell you, it is not. See, the neonatal tetralogy repair is not a widely followed practice. There are isolated centers in the world which have recommended this. It hasn't caught on. Most centers in the world for regular tetralogy would wait till at least 3 months, usually 6 months. And in presence of a cardiac malposition, even the advocates of neonatal repair will not do it in the neonatal period. Okay?
Yes, sir.
Karthik, can
Yes,
I ask?
sir.
See, you have shown the ECG and inferred that there is dextrocardia. How can you infer dextrocardia in an ECG? Because, can you explain?
Yes, sir. There is a negative P wave and QRS in the lead
No,
one and AVR.
Yeah, negative P wave in one and positive P wave in AVR.
AVR.
It's not suggest dextrocardia. It suggests something else. What is that? Situs problem. So you don't diagnose generally dextrocardia directly from an ECG. You diagnose it by ECG, mainly the situs. So if dextrocardia, you commit either on clinical examination on a chest X-ray, then you have to look for a situs by X-ray and ECG. So
Yes,
here
sir.
your ECG actually shows a positive deflection in lead one if you go through this. So anyway, the point is it is the situs which is assessed by the ECG primarily. The second point before I give the mic to sir is that you have said that dextrocardia with mirror image, that is called situs inversus with dextrocardia, has an abnormal conduction pathway. So can you explain that?
Yes, sir. The progression of impulses from the right atrium, and if there is associated VSD, there can be a conduction defect in the AV node and the bundle branches.
No, VSD is far. No. VSD is somewhere away from the AV node. No. See, if you have a situs solitous dextrocardia, then you can have some AV discordance, etc. Then you will have this conduction abnormality or an AV septal defect and all. But in a regular mirror image dextrocardia, I don't think conduction pathway is grossly
Yes, sir.
altered.
Isolated dextrocardia, there won't be any associated cardiac anomalies, sir.
No.
I think you are quite mistaken.
Other way around.
Yeah.
I think you are very tense. That is why. So what you have presented is not an isolated dextrocardia. What you have presented is a dextrocardia with situs inversus. You started by saying that it usually will have hardly any major anomalies. That is why you are presenting this as a poster. That is why we are listening to you. So this is an dextrocardia with situs inversus according to you, which has a complex cardiac anomaly. That is one take-home message that you are giving to us. Alain, what do you say?
Yes, sir.
Yes.
Yes, sir.
Suresh, sir?
No, I agree with what Dr. Sulfikar has said. I'll just amplify the point that situs inversus mirror image dextrocardia has a normal conduction pathway. Like everything else, it is inverted. Obviously, it will come on the right side of the chest. Other than that, the conduction system is normal. And in the VSD, it is in the posterior inferior rim, which is where the conduction pathway is anyway in relation to a VSD. I think we can move to the next one.
Next one.
Okay, Karthik?
Yes, sir.
Well done.
Oh.
Thank you, sir.
Sir, can I go to next, sir?
Yeah.
Yes. This is Rohit Roy.
Morning, respected teachers. I am presenting my presentation on ventriculoseptal rupture on myocardial infarction. It had decreased in frequency in the post-thrombolytic era, but than the pre-thrombolytic era, but the mortality still remains high. This is probably more because in the right ventricular dysfunction and older age, longer delay between rupture and surgery.
Just one thing.
Yes.
One thing. You're not supposed to read out the slide. No, we are only supposed to see the slide only. Since nobody else is presenting, you should not be. Anand, can you listen to this?
Yes, sir. Yes, sir. Sorry, sir. Sorry.
I don't think Rohit should be reading out his slides.
Yeah.
So can we start from the beginning, Anand?
I will do that. I will do that, sir. I will do that, sir.
Yeah. The other thing is that this is not the one which has been sent by Rohit Roy.
No, we haven't got the slides.
This is his second presentation, I suppose.
Yes.
Okay, I think now Anand will start.
This is given by organizer to me. Shibu sir given.
It's okay, sir. It's okay, Anand. You go ahead.
Yeah, no, we are fine. Yeah,
we are not problem.
I'm starting again, sir.
Yeah. So Rohit Roy is presenting two cases. Right.
Yes.
Yeah.
Okay, Rohit?
Yes, sir.
Rohit, we prevented you from talking not because of anything else. It is just that that is not part of the format. We are supposed to read only the slides. Since others are doing the thing, that's why I interrupted you when you were presenting. My comment on this, all your 5 patients died, correct?
Yes, sir.
They were offered device closure or whether they underwent surgery after that, all the patients died. So the message would be that ventricular septal rupture in an anterior wall myocardial infarction carries a very poor prognosis regardless of what you do.
Yes, sir.
I can understand that. What would be what is your understanding of the literature data on this, on the long-term outcome of, or how many people in larger series leave the hospital alive after either device closure or surgery?
Yes, sir.
Do
So
you know of
most of
any
the
data?
Yes, so most of the patients, but the literature says that those who underwent the open heart surgery later on, they had survived better, and that's what I mentioned in my slides also, that when
You can
they
answer
get
to
a
the question. Just answer to the question. So you just said one sentence that surgical results are better than interventional results. Is that what you said?
Yes, sir.
Do you know of any larger interventional series from any country? One of the largest is a series of 40 from the National Health Service. Only 30 to 40% of the patients left hospital alive. So the difference between surgery and this is lower, is narrower. The point is, the earlier you intervene, the worse is your outcome. If you are able to wait a little longer, which means your patients allow you to wait longer, the clinical condition is not forcing you to intervene. If you're able to do that, results seem better. Like if you have done a device closure at 4 weeks after myocardial infarction, almost certainly your patient will survive. But then that patient is surviving till 4 weeks because his condition permits it and you're not forced to intervene. Correct? So an anterior wall infarction presenting in a catastrophe in the first 5 days, the results would be quite poor regardless of what you do. This is what your data has shown. Dr.
Rohit,
Sulfika?
yeah, Rohit, see, as I say, the latent period is at the longer the latent period, better prognosis, which means that the patient is relatively stable. So that is the message you are planning. I mean, trying to give it to us, right? Longer the latent period, which means the longer the time the patient remains stable, there is a better outlook. Here you have what is the latent period here? Average latent period between VSR and the surgical intervention.
around 18 to 24 hours, sir.
18 to 2. Do you think this is short, or you would have a better prognosis if it has been delayed a little more? What do you
So
feel?
the patient's condition was very critical, so
Very
that's why
critical.
we had to intervene early, sir.
Intervene. Okay, exactly. So ultimately, the decider on mortality probably would have been the clinical status, right? Okay.
Good, Rohit.
Oh, yeah, right, nice.
I think you have one. Oh, no, the next is not your case. No? Anand, we can go to the next case. Yeah.
Anand, you can, yeah.
Yeah, starting, sir.
Yeah. Okay, no problem. Harish. Okay.
Yes, sir. Shall I read out, sir?
No. Please don't. Yeah.
The slides will speak for themselves.
Okay, sir.
Harish sir, your video is blank.
I want it, sir. 1 second, sir.
Sir, you can ask.
Suresh sir?
Yeah, yeah, please.
Yes, sir.
Yes. So, Harish, what happened to this cases 2 to 5? 2, 3, 4, 5?
Almost similar presentation, sir. They
All
all
of them
came.
had, or all of them had coronary angiogram.
Yes, sir. All of them had coronary angiogram, sir. And for all of them, it was normal.
Normal.
And
What about
for
enzymes? What about the biomarkers?
yes, sir. Troponin we did, sir. For all of them, it was negative.
It was normal.
Negative. In
Not
our case,
negative,
it
it's
is
normal.
normal, sir. It was
Normal.
normal.
Then can you, before I go to sir, can you educate me on this tryptase?
It's a more
Tryptase.
of tryptase is like there is no specific marker for allergic reaction for such Cowney syndrome. So indirect clue is tryptase to indicate allergic reaction. So if tryptase is positive, which means more of allergy-induced acute coronary syndrome, sir.
Okay. Now, Kuhn described this. This is due to. He said it was due to spasm which produces angina. Here it is myocardial infarction pattern in ECG with a normal drop. So how do you explain that?
Yes, sir. The presentation can be varied, sir. In our series, it was the troponin was normal, but in other cases outside, it has come as more of sometimes ST elevation MA, sometimes it's non-ST elevation MA. Sir.
But do those studies have elevated troponin in those series?
Yes, sir. Some cases had elevated troponin.
Elevated.
Yes,
so all need not be a pseudo myocardial infarction.
Yes, sir.
Sir, Suresh sir.
My question, you have avoided the word coronary spasm all through your presentation.
Yes, sir.
Dr. Sulfikar referred to the initial description referring to spasm.
Spasm.
Yes,
and when you have a normal coronary arteries after having seen an ST elevation, won't you call it spasm?
Yes,
Can't
sir.
you say that this is an inflammatory mediator induced spasm? In fact, some other references would say it is a histamine induced spasm. Whether it is histamine or something else, it is spasm, no? Because I'm not sure whether the word allergic angiitis will stand scrutiny. Because if you say that there's an angiitis, there is an inflammation. And therefore, there is a chance for a platelet adhesion and a thrombus formation. So an allergic vasospasm appears a more correct description of the pathogenesis of this than saying that this is an allergic angiitis.
Oh, yes, sir. Yes, sir.
That's all that I have to comment. Well done.
Yes, sir.
Harish, your paper was good. Well done. Okay.
Thank you, sir.
Interesting situation. Okay.
Thank you, sir.
Sir, I'm starting next.
Anand, can we go to the next play? Whenever you are free. Whenever you are ready.
Ready, sir. Ready, sir. Ready to go.
Okay.
This is Krishna Prasad, no?
Yes.
Good morning, sir.
Good morning.
Dr.
Krishna
Dilshad
Prasad, I have a question to you.
Yes, sir.
I am afraid your two slides seem to be in conflict with each other. What is the basic pathology that you are attributing to have caused myocardial infarction in this? You have seen a lipid-rich plaque on IVUS. You have given the patient DES for treatment. And then in the next slide, you say that this is most likely embolic.
Sir,
So what is your actual conclusion?
So what we feel it has the lipid-rich plaque has caused a critical stenosis, which was aggravated by the embolism from the microembolism from the prosthetic valves.
That such a claim you have not made in your slide.
I mean, that is a kept for discussion. So,
Dr. Sulfika, would you comment on?
Krishna, this thrombolysis, which was actually it's an offshoot of Dr. Suresh's question. This thrombolysis done into this patient, was it basically by default or feeling that it is due to?
No, sir, it was by default as it was a STMA only, because it was done from an outside center. It was done because it was an STMA and it was not possible to shift for a PCI cable center.
She was a 34-year-old lady, no? 34.
Yes, sir. That prompted us to think about this prosthetic valve.
So between this atherosclerosis and embolism, generally, if you have not done an IVS, what would you generally think more likely to be embolism or atherosclerosis?
Embolism, sir, in a 34-year female.
But you don't have any objective data for this. Okay. Now, what is the one take-home message here? Is it because you are dealing with an unusual combination of a triple mitral valve disease with atherosclerotic cardiovascular disease in a 34-year-old lady, or is your message that this in a young person you can have an atherosclerotic with a superadded embolism? Which is the message you are giving?
My take-home message, sir, in these patients, young patients with 34, who have no conventional atherosclerotic risk factors, with high risk factors for thromboembolism, like triple valve replacement. So these patients, we should suspect coronary embolism is the cause of myocardial infarction, and in these cases, many times they can be treated with GP2B3 inhibitors. Of course, I agree that we had to put a DES in this case because we could see a lipid-rich plaque and we could not see a TME3 flow after GP2B3.
Okay. Okay.
Interesting. Good.
Thank you,
sir. Sir, I'm starting next presentation, sir.
Yes.
Yeah.
This is Kumar Manish Raj. Okay.
Kumar sir, your video is blank. Kindly check your camera.
Hello, good morning, sir. Hello, I am audible, sir. Hello.
No.
Yeah. You're audible but not visible.
I can see that, but Suresh sir cannot see, no?
Yeah, I can't see.
Okay.
I suppose Anand also couldn't see. That's it. Anyway,
no, sir,
doesn't matter. Yeah.
Kumar, can you hear me?
Yes, sir. Yes, sir.
Yeah. This interventricular septal aneurysm, what do you think is the most common cause of interventricular septal aneurysm in pediatric practice?
Sir, in pediatric practice, normally the cause is congenital and
No,
the
no, no.
exact cause.
That you have written. But what do you usually see when you follow up this VSDs in small children? Many of them develop aneurysm and close off. That is the most common cause. Another thing is you have been eloquently silent about what happened to this dilated cardiomyopathy part because you are combining apparently a benign thing like IVS or IS aneurysm with a very potentially lethal condition like DCM. So naturally, it may not be linked to each other. Or what happened to DCM? Because asymptomatic, after follow-up, you said asymptomatic. So
Yes, sir.
has the DCM improved with your
Sir,
folic acid and this thing?
yes, a child has improved in terms of symptom has improved, sir. Now child is
No,
having no
what happened
tachycardia
to the
and
dilated cardiomyopathy? What happened to
and
the
ejection fraction has also improved, sir. Like from 25, it has improved to around 35 to 40, sir. But of
percent
course, it's not improved completely, sir.
completely? So do you think homocystinemia is at fault or something else which you
Sir,
cannot?
sir, I'm actually, sir, homocystinemia at this level of 22 may occur because of the vitamin B12 deficiency or
No,
pyridoxine
no. I
deficiency.
want you to answer my question. That is, do you seriously think that homocystinemia is the cause for dilated cardiomyopathy in this patient, or only or an incidental finding?
Sir, it looks like incidental findings, sir, not
Incidental
the whole cause.
Okay. Now, what is the moral of the story? I mean, what do you want to achieve? Last question. Sorry for taking too much
Sir,
time.
actually, just we want to cover all the aspect of the known causes of congenital aneurysm of interventricular septum, sir. That's what the whole workup has been done, and this case has been presented, sir. If we find anything associated with the DCM along with IBS or IAS aneurysm, sir.
Okay.
And that's why we did all the etiological workup as well as the association like Holter
No,
monitoring.
Kumar, stop there. No.
Yeah.
I need a second with you. I do not agree with the diagnosis. There is an aneurysm involving the entire length of the ventricular septum. It is
Yes,
something extraordinarily uncommon. And
Yes, sir.
with that, I would like to see the coronary first. What
Yes, sir.
imaging that if you have demonstrated that the coronaries are normal?
Yes, sir. CT angio we have done, sir.
Okay,
That
fine. No. Hold on.
that was normal.
In which case, I would think there is an apoptosis there. So in which case, that is the primary problem. None of the issues that you have mentioned is the cause for aneurysm. And the LV dysfunction is secondary to this. You need to follow this patient to see what this happens. I'm sure Dr. Sulfikar would agree with me. Have you ever seen an entire ventricular septum being
not at all.
aneurysmal and thinned out in an
Never.
8-month-old baby? So in which
Never.
case, that is congenital. So that there is a congenital loss of substance in that septum.
Yes, sir.
That is influence. That is, after all, the anterior wall of the LV. That LV will not have a normal function. I think you need to follow this child. This is an extraordinarily uncommon thing that you have seen. None of the etiologies that you mentioned are relevant to this patient. Thank you.
Sir, next starting, sir. Next.
Yeah. This is Pranav Shinde. Okay.
This is the infective endocarditis. Okay.
Sir, you can start.
Yeah. See, for now, for a backache, etc., with fever for 10 months and all, you have you have gone to the future, like saying you had started the investigation with a PET scan with a 3/6 murmur and a documented fever for 10 days. You have another continuous murmur also. So, what prompted you to directly go to PET scan?
Sir, actually, that patient was it followed with the orthopedician for the chronic backache. So they were evaluating the patient for the chronic backache. So they had done the X-ray, then followed by the MRI scan, followed by the PET CT for the evaluation of the chronic backache. So therefore, it was the incidental diagnosis there that they found that it is the PDA or there with the metabolically active lesions. There are mostly the infective endocarditis vegetations with the septic pulmonary embolia.
So you mean to say that this patient was probably never seen by either a physician or a cardiologist because
sir, he was admitted with the physician for the fever, sir. But at that time, sir, echo was not done.
But clinical examination, you said 3/6 pansystolic murmur and 2/6.
Yes, sir. Yes, sir. Yes, sir.
Yeah, and that is the point you are highlighting, right?
Yes, sir.
Okay, right, sir.
No. Did I miss the report on the culture? What was the culture?
No, culture was negative.
Sir, culture was negative, sir, because he was initially on the antibiotics.
Okay.
Maybe that's why the culture was negative.
Okay, with large vegetation.
Yes, sir. Yes, sir.
Huge vegetation.
That's surprising. And the vegetation settled fortunately without surgery.
Yes, sir. We have advised him surgery, but patient was not willing for surgery. So he gave consent and he went.
Sure. I get it. Anyway, it settled without surgery.
Yes, sir. Yes, sir.
Okay. Luck for the patient and for you.
Yes.
Good. Well done.
Sir, can I start next, sir?
Please.
Yeah, definitely.
Okay, thank you.
Shilpi Lahoti. Okay.
बट मेरा फोटो नहीं दिख रहा है इसमें.
Sir, we can start, sir.
Hello, Shilpi.
Hello, sir.
You start.
Good morning. Yeah, Shilpi.
Good morning, sir.
Good morning. What is the reason for stroke in this patient? Is it AP window or Eisenmenger syndrome?
So in this patient, I think it's because of Eisenmengerization, which has caused the complications of Eisenmengerization, which led to stroke in this patient, sir.
Yeah. So therefore, that AP window is the cause for the stroke is a little misleading, no? If you Eisenmenger syndrome in an young person is a reason for right to left shunt and stroke. And one of the reasons for Eisenmenger syndrome is an undetected AP window turning into Eisenmenger rather early, because since there is nothing to control the flow from the aorta to the PA, occurrence of pulmonary hypertension is very fast in AP window. So it's an Eisenmenger which is responsible for this.
Okay,
And
sir.
therefore,
Yes, sir.
it is not an uncommon thing. And among the causes for Eisenmenger syndrome, of course, AP window is way below VSD. To that extent, you are right in saying that there's an uncommon cause. But don't mistake it. The basic reason for the right to left shunt is Eisenmenger syndrome. Okay.
Right, sir. Right, sir.
Dr. Sulfikar?
Shilpi, you have totally avoided the term Eisenmenger syndrome. Was it by choice or by by default? Because you wanted to highlight the AP window part and the combination of an AP window with a stroke. But what Sir said was right, in the sense that it is an Eisenmenger AP window which has produced a stroke, most likely due to a paradoxical embolism. Now, AP window, how early can it develop PVOD, Eisenmengerization? At what age? Usually the development, not the presentation, the development.
I think,
Shilpi?
yes, internet some problem is left.
Okay.
Oh my God, that's sad.
Can I start next, sir, then?
No. Yeah, that's a problem.
Let us see whether, after all, she has another 55 seconds to her credit.
Okay. If there is a connection, we will ask her that question.
Yeah. Because she shouldn't feel that, she had a disadvantage.
Correct. 1 minute does not make a difference.
Yes, after all, we are keeping time very meticulously.
Yeah, I've been observing that also. Shilpi, can you hear us? No.
Yeah, no.
Okay. Then we'll have to go ahead with the next case. Yeah.
Maybe if we have time, we can ask her a question later.
Yes.
Okay.
And if she's persistent enough to stay there.
Yeah, she will.
Can I go next, sir?
Yeah,
please.
This is Logesh. Okay, Logesh.
Yes, sir.
Shilpi, sorry, this is Logesh, right?
Logesh.
Yes, sir.
Yeah. See, there are a lot of dysmorphism in this baby. You have described it very beautifully. I mean,
yes, sir.
Excellent. What do you think? All this belong to Marfan syndrome?
No, sir. Actually, we had a very close differential diagnosis. We had two differential diagnoses in our mind when we started working with this case.
What were they?
One is Marfan syndrome. The other one is close mimicker of Marfan, which is Bell syndrome.
Which is that syndrome? Which is that syndrome?
Beal syndrome, congenital arachnodactyly. Contractural arachnodactyly. The Marfan syndrome, when it was described in 1989 by Anthony Marfan, the case which was reported was actually a CAA, not actually Marfan. But that time genetic studies are not there.
No, Lokesh.
So
just stick to the question and the answer. First question was specific.
Beal syndrome. We had another differential diagnosis, which was Beal syndrome.
That's okay. Second, you said that RV size was normal. Your comment, but the echo definitely showed a significant RV dilatation. So that
we actually measured it, sir, and we calculated the Z score, so which was not actually high.
RV
so,
in this newborn.
I think your C score should be wrong. If you have severe tricuspid regurgitation, a 5-day-old baby, and if you want us to believe that RV is not dilated, there is something very unphysiological about the whole thing. It is more likely your C score is wrong.
Sorry.
So better to look at the ventricles rather than.
Then always follow the C score. The other thing which I wanted to say, do you see any similarity between the presentation of this baby and that of an Epstein's anomaly?
Yes, sir.
And as far as the cardiac presentation, which you have highlighted, is concerned, if I say there is an overlap with Epstein's anomaly, can you tell me what is that overlap? What has happened?
The same child will present with cyanosis in younger age, sir. But
I'm not suggesting that this is Epstein. So since what you have highlighted as the key feature of your presentation is tricuspid regurgitation, right to left shunt, and cyanosis on day 1.
Yes, sir.
That is typically a feature of Epstein.
Yes, sir.
So what is common between the two is tricuspid regurgitation causing a right to left atrial shunt due to a high PVR, which comes down and the baby becomes all right.
Yes, sir.
Fortunately for the baby and you, this baby's only clinically significant lesion at this point is the tricuspid regurgitation. MR is mild. Aorta, though dilated, there is no aortic regurgitation. It is not, aorta is not big enough to rupture now. So the presentation has been guided by tricuspid valve prolapse worsened by the neonatal PVR causing TR and right to left shunt.
Yes,
Otherwise, a newborn with florid Marfan's anomaly, Marfan syndrome, is at a high risk of sudden death, either from mitral regurgitation or from ascending aortic rupture. In general, as a pediatric cardiologist, I'll be very worried if the neonatologist calls me with a diagnosis of Marfan syndrome on day 1. That baby's survival chances ordinarily would be low.
Yes, sir.
But your baby fortunately had only tricuspid regurgitation.
Yes, sir.
That is the point that I wanted to tell you.
Thank you.
It's an interesting case. And you have the genetic diagnosis. Well done.
Thanks, sir.
So starting next, sir.
Yeah. Fanny Coniday. Okay. Sir.
Yeah, Funny. Funny, can you hear me? Do you hear me, Funny, the presenter?
Unmute yourself, please. Unmute yourself, please.
Yes,
Can
sir,
you
I'm
hear me?
able to.
Okay.
Yes, sir, I'm
Now,
able to hear.
you have described the multiple valve prolapse in acute rheumatic fever.
Yes, sir.
You're familiar with descriptions of echocardiographic involvement of the various valves in acute rheumatic fever?
Yes, sir.
In mitral valve, what is the common evidence, echo evidence of rheumatic involvement?
Common in rheumatic carditis, it will be usually mitral regurgitation, sir.
No. Mitral regurgitation. What is the morphology?
Morphology.
Yes,
You
sir.
have chosen to describe one morphology, that is mitral valve prolapse. That's
Yes,
why I'm
sir,
asking, what is that? Yes? It is
usually the elongation of the caudate tendinous, sir, or else annular enlargement of the mitral valve. Right?
No, neither of the two, because elongation of the caudate tendinae is usually congenital. That is an evidence of mitral valve prolapse. Dilatation of the annulus is also congenital. That is goes more with congenital mitral valve prolapse. You will need severe mitral regurgitation if the mitral annulus is to dilate in rheumatic fever. So you haven't answered the question, what are the echocardiographically detectable changes in the mitral valve in acute rheumatic fever? I thought this is a very common question for you.
Mitral valve thickening will be there, sir, initially.
Is there any further description? Thickening, even I will say. You should be able to say better.
Thickening and beaded appearance will be there, sir.
Beaded appearance could be there. Thickening is there. Okay, so this patient had any of these?
He is having a beaded appearance, sir.
Yeah, you
Thickening.
never described it. You chose to describe prolapse as the feature of rheumatic involvement while ignoring your beaded appearance and the thickening.
Yes, sir. Actually, beaded appearance was there, sir.
Yeah, then I think that is the thing that you should highlight, no? Because pathologically, we would be very curious as to how the prolapse disappeared over few weeks and the regurgitation came down.
Yes, sir. Actually,
It
patient
is
was having beaded appearance. There was no much thickening, sir, but elongation of the chordae was there. Patient having mitral valve prolapse with severe regurgitation was there, sir.
Yes, one of our colleagues have described the rheumatic involvement in considerable detail and published. You are probably familiar with her criteria.
Yeah, yes, sir. Vijaya's echo criteria.
Dr. Vijayalakshmi's criteria.
Yes, sir. Dr.
Even
Vijayalakshmi.
if you don't remember the criteria, the meticulousness with which she has described the individual findings, you should note.
Yes, sir.
And don't be carried away by seeing the prolapse and saying that the regurgitation came down with steroids. It is not the prolapse which is influenced by steroids. It is a rheumatic valvulitis. The evidence of that is your beaded thickening.
Yes, sir.
Okay? Good. Dr. Sulfikar?
Funny, you must always also be aware of another morphological classification, World Heart Federation 2011 as a postgraduate. You should go back and learn about that also. Another thing is, can you teach me how do you assess aortic valve prolapse on M mode?
M-mode aortic valve prolapse, you have to see in M-mode how much amount the wall.
Which valve? Aortic valve. Okay, you teach me.
We have to see the deflection, sir. Deflection and the systolic deflection, we have to see how much it is deflected. If it is more than 2 mm, we have to think of there is a prolapse.
Are you aware that a significant proportion of this rheumatic carditis will have prolapse also?
Yes, sir. Significant proportion, 95% of the patients will have
some degree of prolapse. Okay, Fanny. Okay.
But involvement of all the three valves is little bit rare, sir.
Yeah, with two valves are very easy, no?
Yes, sir.
Yeah, always prolapse business, correct. Okay.
Yes.
Okay, Fanny. Well done.
Thank you, sir.
I'm starting next. Sir, the Shilpi madam asked some request. Can we have the question answer round again?
Shilpi, but Sulfikar, I have forgotten the question.
Shilpi, what was the case? I wanted to ask her one question. Shilpi is now free.
AP window, yeah.
AP window. Oh, okay. I asked her, how early can AP window develop Eisenmengerization?
Shilpi madam around? No.
Shilpi is around?
No. She gone back.
Okay, right.
Okay, then let's go to the last case.
Yeah,
Rohit Rai.
Yeah, started, sir.
Rohit. Rohit.
Yes, sir. Good morning.
Yeah. What is the single carry home message that you are sending to cardiologists and physicians and obstetricians to our country?
So that in this case of CV,
There is an audio problem.
is preferable to surgical management.
Is that the message? Because nowadays, even otherwise, young people, they are undergoing BMV. So BMV is the standard care. So what is that particular message? You are not comparing surgery versus BMV and all. This is a no. So what is the message? Final message to the physicians, obstetricians.
So that BMV has got a better, has got a good outcome in cases of pregnant women with RHD with cesareans.
And finally, uneventful completion of
Yes, uneventful.
and all of them had a vaginal delivery. Right.
Yes, yes.
Okay. What is the fluoro time? Did I miss that?
7 minutes. It is there. 7 minutes. Yeah.
Okay, sir. Sir, please.
7 minutes.
Yeah. Rohit, I have one question. Just as Dr. Sulfikar asked you about the fluoro time. You have some idea as to what is your mean fluoro time for the regular non-pregnant female or for the regular patient?
So it varies around 10 to 12 minutes, sir.
So you have definitely been able to cut down the fluoro time in the pregnant woman.
Yes, sir.
Second thing, have you maybe not as part of this paper, but from your center, which does a large number of mitral valvotomies, the outcome of this, of course, that the women went through pregnancy uneventfully and delivered vaginally is a great thing. But if I look at it from an interventionist point of view, I would be curious to know whether the valve area that you achieve, the redo valvotomy that these people undergo, is it any different in this patient versus your regular patient? Like if I make a theory, can you refute saying that at the end you have got a smaller mitral valve area like 1.6 mean, that within 5 years 3 of them have undergone a redo valvotomy, which does not happen to your regular patient? I'm just giving you a theoretical scenario. Do you get my point? I don't think you did. I'm just asking you, but since you're doing a faster procedure, is it possible that the final outcome in terms of the valve area and the need for redo procedures is higher in these compared to your regular patients? Or it is the same?
So we need to follow up those patients for
No, that's all okay. Do you know the answer to this or you don't?
No, sir.
Okay, that's fine. You don't need to. I'm just asking you whether you have such an information. Very good. It was a good paper, Rohit. Now, Pranav Shinde wants to add as a presenter. What did Pranav Shinde do?
His time is over, sir. You want me to admit?
No. He has finished.
Okay, sir.
No, nothing else, no?
No, as far as it is over, no?
It's over, sir.
Yeah. Congratulations to all the presenters, and we enjoyed listening to you.
So one thing I want to tell, or if they are listening to us, two things actually. One is the...
sorry, Sulfikar.
Yeah.
Shilpi is there. Shilpi is there. Would you like to ask a question?
Shilpi is there. Shilpi, how early can AP window develop Eisenmangerization?
Second, sir. I just admitted. She is with Rohit, it seems. Unmute yourself and talk, please. Hello? One second.
Shilpi is very elusive.
The Scarlet Pimpernel. The female Scarlet Pimpernel.
Sorry, sir. I don't know what was.
Very good. Very good. Nice.
Welcome back. We are waiting for you.
Come back.
Yeah. Did you hear the question? Did you hear the question, sir?
No. So sorry, sir.
Yeah.
I was.
Oh, that's okay. Shilpi, I wanted to know how early an Eisenmangerization occurs in an AP window compared to the regular post-tricuspid.
Most of the AP, yes, sir. Most of the AP windows they are found to be large. So as early as 8 months to 1 year.
How early can they develop Eisenmangerization?
So 8 months to 1 year.
3 months to 1 year. Okay, 3 months.
8 months, sir. 8 months to 1 year.
8 months to 1 year. Okay.
Good, Shilpi. We missed you. I think we are done.
Yes, sir.
Anand?
Sir, done, sir. Thank you so much, sir.
So thank you so much. Zulfikar, എന്നെ എന്ന് വിളിക്കാമോ?
ഞാൻ വിളിക്കാം സർ, തീർച്ചയായിട്ടും.
Sure.
Thank you, sir.
Okay, all the best to all the presenters.
Thank you, sir.
Okay.
Okay, Anand, bye.
Bye, sir. Thank you, sir.
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
Ashish, good morning.
Good morning.
You are
Muted. You are muted.
Our session will
It's quite a long time. Are you concerned of taking vaccine? Are you concerned?
then you end up
one minute more. I don't know whether technical problem at the Ahmedabad studio. We will be waiting as soon as the link to the delegate platform is ready. I will let you know.
Sure.
Yes.
Good morning, Professor Tyagi. Well,
Good morning, Dr.
sir.
Tyagi. 10 o'clock. Okay. Good morning. I think yesterday we had a very full session, but for some technical problems, I think now everything is sorted out. So we can start this session. Chairpersons, please.
Thank you, Anand. Good morning, delegates. Welcome to the session 42 on day 2 at Hall Narmada. This is on the great expectations with respect to aortic disease. I invite Dr. Ashish Kumar from Cochin, Kerala to present his talk on endograft treatment of ascending aorta and update. Over to you, Ashish.
Thank you, sir. Good morning to all. Disease entities involving the ascending aorta have always been the surgeon's domain. And this segment of the aorta has traditionally been considered out of bounds to the endovascular specialists, and for understandable reasons. Having said so, there have been enterprising interventionalists who are brave enough to transgress the unexplored terrain of the ascending aorta, and the first case report of a balloon expandable stent graft in the ascending aorta was published in the Journal of Endovascular Therapeutics in the year 2000. There have been anecdotal reports ever since the off-label use of thoracic grafts and abdominal aortic cuffs to treat ascending aortic disease. The disease entities could be acute aortic syndromes, starting from type A dissection through pseudoaneurysms, penetrating atherosclerotic ulcer, intramural hematoma, and the chronic disease entity of aortic aneurysms. We said this has been the surgeon's domain, but are the surgical results so impressive that other treatment modalities need not be considered at all? If you look at the facts, close to 30% of patients presenting with acute aortic syndromes have been denied surgery, and this is the data from the International Registry of Aortic Dissection. The current estimate would essentially be close to 10 to 15%, but still a sizable number. A mortality of 1 in 5, neurologic dysfunction 6%, half of this being permanent. If you look at disease-specific entities, the in-hospital mortality for pseudoaneurysms and penetrating atherosclerotic ulcers is close to about 16%. Fortunately, both of these entities present as saccular aneurysms and could ideally be suited for endovascular therapy. Occasionally, we would be fortunate enough to tackle this by deployment of devices, as in this case, but often we are not that lucky. So conceptually, endograft treatment of ascending aorta can benefit two subgroups of patients. One, those who are unlikely to tolerate complex high-risk surgery. And number two, as a bridge to convert an emergency surgery to a more elective, definitive repair. And the rationale for such a concept is the observation that in an emergency setting, the operative mortality is at least 5-fold as compared to elective surgical repair. So the concept looks good, but is it feasible? This is a CT-based feasibility study which looked at a cohort of 102 patients with type A dissection. Approximately half of these patients who underwent an open repair could potentially have been treated by an endovascular repair if, a big if, appropriate stent grafts were available. So the concept and the feasibility appear great, but there are challenges. The ascending aorta is a short and wide tube. There is a sharp angulation which leads to a marked disparity in length of the inner aortic curvature. The endograft has naturally to conform to these measurements. The delivery system should be long and flexible to come up and over the aortic arch and reach the ascending aorta. The nose cone should be short enough so that even though it enters the LV, it does not go deep down and injure the myocardium. Needless to say, the margin for error in this segment is extremely minimal, and the deployment of the graft has to be as accurate as possible. Challenge number 2, the proximity to the structures. The aortic valve of the coronary ostia proximally, the innominate artery distally, and we need to land the graft proximally as proximal as possible, close to the coronary ostia. Occasionally, to widen the horizon, we need to address the aortic valve and sometimes incorporate branch grafts to address the innominate artery involvement. So essentially, the treatment has to begin and end in zone 0, but the whole of zone 0 is not alike. So people have sub-categorized zone 0. On the left, we have the Cleveland classification, and on the right, the Chinese classification, basically dividing zone 0 into 3 segments, and the mid segment, or the 0B on the left, would be the most ideal for endovascular approaches. We said the previous treatment modalities were using off-label use of devices, and the first case report of a device designed for the ascending aorta was published in the Journal of Vascular Surgery 2012 for a case of intramural hematoma, for which they deployed the Scenic Ascent, a dedicated stent graft made of nitinol with a polyester spoon. Over that, bare stents, both the proximal and distal, a covered length of about 65 millimeters, and which can deal with aortic diameters from 22 to 38. The devices are from 28 to 46 millimeters. This is how it looks like. As I said, proximal and distal bare stents. And the delivery system is so designed that some degree of repositioning is possible after partial deployment so as to facilitate accurate positioning. Now, there has been slightly larger, even though small numbers of case series of 10 patients published 4 years later, reasonable success, acceptable complication rates. And this is how the pictures look like after deployment. The arch vessels are all flowing, the coronaries are flowing as well. And 2 years ago, we have a systematic review of primary endovascular repair of the ascending aorta, incorporating 118 patients over a 22-year period, half of these being type A dissections, 30% pseudoaneurysms, large use of thoracic endografts and extension cuffs in about 11%, mortality 15%, type 1 endoleak in about 1/5 of these patients, only half of these required reinterventions. So we know that in a type A dissection, the vast majority being type A dissections, the only structure which is not affected by the dissection is the aortic valve, but aortic regurgitation is not a contraindication for endovascular repair of type A dissection, as has been shown by our colleagues from Cleveland. The dissection, once treated, the commissures and STJ come back to the original position and the aortic regurgitation settles. But occasionally there could be cases wherein we need to address the valve, and herein we need to embrace the technology of TAVR plus TWAL. Coming to aortic aneurysms, a separate entity, we know that at least 30% of ascending aortic aneurysms involve the arch as well. So any treatment modality or design of the graft should encroach the arch as well. Nexus is one such device from Endospan, marketed by Jotic, specifically designed to treat aneurysms involving the arch and extending to the ascending aorta or vice versa. It has 2 components, the ascending module, which is deployed in the ascending aorta, the main module with its side branch of the brachiocephalic, and on the extreme right, we have the final assembled device. It has a dock and lock mechanism, and the delivery system is designed so as to minimize manipulation in the arch. The first case report published in the Journal of Thoracic and Cardiovascular Surgery in 2017 using the Nexus device. This is a hybrid approach because as of now, it requires a bypass of the left common carotid and an optional bypass of the left subclavian artery from the brachiocephalic. But I believe the next generation is incorporating a precannulated fenestration for the left common carotid artery, which essentially takes away the need for a supraortic surgical deep branching, and the device is due for commissioning in 2021 and 22. So this seems to be a promising technique because it provides protection against migration because of its landing the brachiophatic artery. Some of these definitely require surgical approaches. So we can look at it not just as pure endovascular, but hybrid approaches. This is one such approach, a simplified extended aortic repair. We know that the elephant trunk and its modification, the frozen elephant trunk, have stood the test of time, but has requires a lot of expertise from the surgeon. So to make it more simple, this system actually what it provides is there is a covered stent, a covered portion of the stent graft deployed in the descending thoracic aorta, and an uncovered portion in the arch. And this facilitates a surgeon to anastomose in zone 0 instead of zone 3. And what it does is it decreases the ischemic time and the hypothermic circulatory arrest time as well. And the indications for this kind of eNovia, this device from Jotec, it is ideally indicated for very sick patients, the elderly, those with concomitant disease, and pen classifications B, C, and BC, that is associated with branch vessel malperfusion, circulatory collapse, or both. And the first case report was published 6 months ago in the Journal of Thoracic and Cardiovascular Surgery. The last frontier in ascending aortic disease is the Bental, the endovental concept for proximal aortic dissection. From conception to application, published 6 months ago, basically an endovascular valve carrying conduit with a proximal transcatheter valve connected to a stent graft, which could address all these issues. And there was a feasibility study published 2 years ago, again in the same journal, wherein it was felt that 2/3 of all patients with acute aortic dissections are potential candidates for endovascular treatment. And the concept may help to significantly improve survival in patients with acute aortic dissection. Conceptually, we have the stent graft, the valve, the balloon expandable valve as of now, and there are external branches through which we can access the right and the left coronary arteries. A proceed sealing proximally, balloon expandable valve as of now from Braille, and the external and internal branches on the right as you can make out. The first case was done about 18 months ago, published 8 months ago in the JACC journals. And this is the whole procedure line. You have...
Dr. Ashish, your time is over. Can you conclude?
Yes. So as of now, the external branches, the subsequent version will have inner branches so the device is less bulky, and the version 3 will have pre-cannulated inner fenestrations through which you can access the coronary arteries. So the take-home message, feasibility of TWAR ascending aortic has been demonstrated by multiple groups with impressive results even in emergent scenarios. You require dedicated stent grafts with better conformability and sometimes branch grafts to address the supraortic branches. Having said that, not all patients can be considered for TAVR, even if they are unsuitable for or high risk for surgery. The most important factor for success is patient selection, the conformability in the sense, the proximal and distal landing zones of 1 centimeter, no vein grafts. So the concept of total endovascular solution is evolving, and the future looks promising for patients with ascending aortic disease. Thank you for your attention.
Thank you, Ashish, for a wonderful presentation. It is an evolving technique. Actually, the management of ascending aorta is actually it's a surgeon's domain. It has been the surgeon's domain all along. But the newer devices which you have showed definitely shows an evolution in the way we can manage the ascending aorta.
We will have the discussion after all the 3 talks. So
okay, Peter. Okay, I'll call upon Professor Sanjay
Mehrotra, yes.
To deliver his lecture on new treatment of type B aortic dissection. Sanjay.
Thank you, Dr. Srinivas. What is new in the treatment of type B aortic dissection? So as you know, aortic dissection, which is the most common catastrophe of the aorta, is 2 to 3 times more common than the rupture of the abdominal aorta. A classic aortic dissection involves the formation of a dissection flap, which divides the aorta into true and false lumen. The entry tear, of course, is located somewhere in the part of the aorta. And the old classification, which was the Becky types and the Stanford type, was a bit simplistic, where the location of the entry tear was either in the proximal aorta in the Stanford or in the distal aorta. But there has been a new classification which is being suggested by the Society of Vascular Surgery and Society of Thoracic Surgery.
Your slide is not in the full screen. Can you click the click? Yes. Thank you.
The zone wise, it remains still. There are 11 zones which are divided starting from zone 0 to zone 11, as you see in this picture. The type A and type B remains the same, but there is also a discussion about where is the entry tear located and what is the extent of a dissection. For example, an entry tear may be located in the zone 3, but the proximal and distal extension of the aorta may be from zone 0 to zone 10, and this is a new classification. For here, you can see where is the entry tear in the middle. You can see the entry tear is in zone 3, which is type B, and it extends from 1 to 9 zone. And so the classification is type B19 or type B09, where the location is starting from 0 to 9. So this is it gives you a better idea about the location of the entry tear. Then the same society also made you understand what is the time duration of classification in terms of what is called as a hyperacute, which is less than 24 hours, acute, which is 1 to 14 days, subacute, which is 15 days to 19 days, and anything which is beyond 90 days is called as chronic dissection. An uncomplicated dissection which does not have any rupture, any malperfusion, or there are no high-risk factors. On the other hand, the complicated dissections which has got rupture and malperfusion. What are the features of high risk? Refractory pain, refractory hypertension, bloody pleural effusion, aortic diameter which is more than 40 millimeter, radiographic malperfusion, readmission with pain or any other reason. Entry tear on the lesser curve is also a high risk feature. And if your false lumen diameter is more than 22. Now, as we all know, type A dissection, the mortality is higher in the initial period, hence it needs surgical treatment, but it's stable in the later period. On the other hand, acute type B dissection, mortality is relatively low, and of course, unless it is complicated, the treatment is medical in the beginning. Here is a 32-year-old gentleman who developed sudden chest pain followed by severe pain in the right lower limb and was confirmed to have type A dissection. You can see the type A dissection here, but his right common iliac artery is occluded. So how do you treat it? So obviously this patient came with significant pain in back and ischemia of the right lower limb. So you can see there is no flow into the right lower limb. So we planned for a fenestration for this patient, and you see post-fenestration, there is flow into the right iliac. This is the you can see some flow coming, and then you deploy a stent, self-expanding stent to establish the flow, and you can see how the pressure changes in the right lower limb. And this patient ultimately has to go for a Bentall procedure later. So uncomplicated type B dissection is well tolerated and initial treatment is medical. What are the goals of therapy? Reduce wall stress and false lumen pressurization. Aims of treatment: control heart rate, control blood pressure to reduce the delta P by delta T, which is dP by dt. Medicines which you use are beta blockers, alpha blockers, beta blockers, labetalol. If you give sodium nitroprusside, make sure that you are giving beta blockers, and adequate analgesia is important. Now, complicated type B dissection, which I said is malperfusion of aortic branches, refractory hypertension, periaortic hematoma, pleural effusion, and also false lumen ruptures, which is suggested on a CT. TVAR is the first line of treatment. TVAR seals the proximal antitear, and indications are now expanding to uncomplicated dissection. The malperfusion can be caused by a dynamic obstruction or a static obstruction. How you treat malperfusion, either endovascular or a better control of BP, sometimes can change the flow dynamics of the flap which is obstructing and result in a better perfusion. This is fenestration, which I have told you. You go from the true lumen, puncture the intimal septum, either dilate with a balloon, and I sometimes share it, which I have done many times, or you can, to increase the perfusion, you can put a bare metal stent, which is self-expanding in the true lumen across the splanchnic vessel to enlarge the flow into the true lumen so that the patient can be treated quickly. TEVAR for type B aortic dissection does not prevent aneurysmal degeneration because most of these people ultimately land up with requiring further procedure. So what are the treatment options for post-dissection of thoracic aortic aneurysm? Of course, you can do open repair. And of course, now we have treatment for false lumen. And also, you can do a complex EVAR and prevent by controlling medically, which is called as best medical therapy for such patients. What do you do for false lumen? It limits aortic coverage, technically is less complex procedure. What are the things which you can do? You can use detachable balloons, thrombin, iliac occluder, glue, and of course a candy plug. This is a newer technique which is called as the Knickerbocker technique, where you deploy a larger size of a stent and expand this with a balloon so that you actually approximate the intimal flap to the wall of the aorta by causing obstruction of the flow, and the false lumen can be obliterated. Then you can do extension of the graft with fenestration, and of course put a bare metal graft, a bare metal stent, which is called as a dissection stent, and complete the procedure by treating the whole aorta completely. This is another technique, which is a slight modification of the petticoat technique. In petticoat technique, you provisionally extend the stent graft using a dissection stent to approximate. Timing is important. The other technique is that with the help of a balloon, you disrupt the intimal flap and relaminate by putting a dissection stent, which is called a stabilized technique. So they are complementary to each other, but there is a certain timing which has to be used for stabilizing this patient. Also, not to forget that we have started doing all these procedures, even a 25 French, completely percutaneously. So we don't involve a surgeon at all, and even a 24 or 25 French device can be treated. And this is how a patient looks like as soon as you have completed the procedure. And this patient can be discharged in 2 days' time. You can finish a procedure within 45 minutes using this technique. There is some new application of computation modeling for the risk prediction of type B aortic dissection. When they look at the shear stress, they look at the velocity of the flow. They call it TOS, which is time average wall shear stress, where you can find out what is going to be the future of this dissection and predict a possibility of an early treatment. This is a new understanding using computer modeling, using shear stress and finite element analysis. Now, this must be my last slide before I go to the conclusion, that the IRAD classification of type B dissection, where you compare the endovascular management, medical management, and surgical management. And as you know that the surgical management of a type B dissection is associated with high mortality and morbidity, including paraplegia. The medical management, of course, was advised in uncomplicated dissection, but all uncomplicated dissection lead to further aneurysm formation. And that's where more and more now usage of endovascular treatment in the form of a TEVAR with complete sealing of the and creating a laminar flow causes a better remodeling of the aorta, and that is gaining grounds. And in times to come, we will probably start treating them more and more, even if they remain uncomplicated. Of course, the timing would be important. So in conclusion, dissection of aorta is a devastating disease with high mortality and morbidity. Understanding the disease using imaging is the most important step in its management. Most type B aortic dissection that are medically managed progress to aneurysm, increasing the evidence of adverse events and mortality. Early thoracic, endovascular, and aortic repair results in favorable aortic remodeling, which prevents the aneurysm formation. And to avoid aortic complication in uncomplicated acute type B aortic dissection, early TEVAR may be selectively considered and is gaining grounds. Thank you very much for your attention.
Thank you, Sanjay. It was wonderful presentation on type B aortic dissection, and you in fact have given 1 minute extra to us. Thank you. We'll have the discussion towards the end. I think I'll invite Dr. Rajesh. to speak on inflammatory aortic aneurysm. What is the management? Dr.
Morning to
Rajesh.
all of you. Can you hear me, sir?
Yeah, we can hear you loud and
okay.
clear.
Very good morning to all of you. The topic is inflammatory aortic aneurysm. What is the management? Actually, the inflammatory, this entity was first reported by Walker when he found that an unusually thick wall of the aorta is surrounded by extensive fibrous adhesions involving the adjoining tissues in certain cases. He noticed intraoperatively a white, shiny aneurysm. Actually, this is characterized by a triad, a thickened aneurysm wall, extensive perianeurysmal and retroperitoneal fibrosis, and dense adhesions of the adjacent abdominal organs. About 19% of inflammatory aneurysms are associated with autoimmune disorders. But here I want to clarify that there should not be a confusion regarding that term. For example, the aortitis can have infectious as well as non-infectious etiologies. We have large vessel vasculitis due to Takayasu's arthritis, medium vessel vasculitis due to vaginas, then idiopathic conditions and radiation-induced aortitis. Actually, this inflammatory aortic aneurysm is an idiopathic condition which satisfies all the three criteria which I have mentioned. That is, an aneurysm in Takayasu's arthritis need not be considered as inflammatory aortic aneurysm. So only if the three criteria are fulfilled, we can call it. Now, this figure shows that there is extensive adhesion of duodenum, then renal veins, ureter, sigmoid colon, etc. In this particular patient. Now, about pathogenesis, actually it is said that most of these aneurysms develop as usual non-inflammatory and subsequently change to an inflammatory aneurysms. So what exactly results in it is really not known. There are various theories like reaction to retroperitoneal blood, then compression of the lymphatic vessels by the aneurysm, then an antigen that is elastin-derived protein, genetic predisposition, HLA, DR1, DRB1 locus, as well as the role of IgG4. This is usually seen in the infrarenal abdominal aorta, and the presence in the thoracic aorta is extremely uncommon, and the posterior wall of the aorta is spared. Now, there are certain striking differences between an inflammatory and non-inflammatory abdominal aortic aneurysm. For example, this inflammatory aortic aneurysms are seen in almost 10 years younger patients, that is 17 non-inflammatory and 16 inflammatory. Then more male predisposition, then family history is seen in 17% of patients with inflammatory aortic aneurysms. They are heavy smokers. Then unlike the non-inflammatory aneurysms, which are often asymptomatic, this is 80% are symptomatic. They have signs of systemic inflammation like elevated ESR and CRP. Their prognosis is bad and the surgery is usually more technically demanding. The clinical triad is abdominal pain, systemic symptoms like fever, weight loss, and an elevated ESR and CRP. Then the one confusion which can arise is if the radiologist see a AAA with severe abdominal pain in the patient with peri-aortic enhancement in the contrast CT, he may wrongly diagnose it as a ruptured aortic aneurysm. Then, as I told, the prognosis is bad in inflammatory aortic aneurysms. The radiologist will first get the clue regarding this etiology by noting an inflammatory halo around the aneurysm like this. The CT will show a typical four-layered appearance: the lumen, the thrombus, the aortic wall, as well as extensive peri-aortic fibrosis. And this is what I told, the posterior wall is spared. And this is the PET CT showing intense inflammatory reaction, and it cannot differentiate inflammatory aortic aneurysm from an infectious cause of aneurysm. Now, what is the treatment? Though I told that this particular aneurysm is less prone for rupture, the aneurysms must be treated when the size exceeds 5.5 centimeters. Now, but the role of medical and supportive therapy, that steroids and immunosuppressants are definitely required even after surgical treatment or even after EVAR to prevent the progression of the fibrosis around the aorta. And sometimes the urologist will have to help by putting a ureteric stent for the stenosis. Now, coming to the surgery, the surgery was considered as the gold treatment for inflammatory aortic aneurysm till 10 years back. Both approaches, that is transperitoneal as well as retroperitoneal approaches, were tried and it was tested in a randomized controlled trial by Cambria, and he found no significant difference between the two approaches. The incidence of obstructive uropathy is 25%. The preoperative chronic renal failure is 30%, and there is a slightly higher incidence of long-term pseudoaneurysm formation. Now, there is a 30-year review of surgical experience showing that if a carefully done surgery, then the prognosis of both inflammatory as well as the ordinary aneurysm after surgery is almost the same. Now, what will happen to the retroperitoneal fibrosis after surgery? Data from Paravastu showed that about 70% in cases there is significant regression of retroperitoneal fibrosis. But the importance is that you have to do a long-term surveillance of these patients to detect renal complications like hydronephrosis and renal failure. And of course, the patients must be on steroid and immunosuppressive agents. Now, as cardiologists, our concern is there any role for EVAR in this particular group of patients? The only concern is that a patient may develop an inflammatory response to the fabric in the endograft. We have done actually many cases of EVAR thanks to Dr. Sanjay as well as Professor George Joseph as well as Ashish, the guys who have trained us in doing this procedure here. Now, what is the difference in endograft treatment of inflammatory as well as non-inflammatory aortic aneurysms? The Eurostar data shows that the main danger was the limb occlusion in inflammatory aortic aneurysms. Otherwise, there is no significant difference. The long-term prognosis is same. There is slightly worsening of higher incidence of worsening of the renal function in inflammatory abdominal aortic aneurysm. Now, a review of open surgery versus EVAR shows that definitely EVAR is associated with a lower 1-year mortality. But you should be careful in choosing this modality of treatment only to those patients who are free of hydronephrosis and renal complications. Again, a comparison of open surgery versus EVAR. The EVAR should be considered as a first-line therapy only in patients where there is no ureteric involvement. Now, there is a meta-analysis on the endovascular therapy of inflammatory aortic aneurysms, and they conclude like this: EVAR is quite feasible, excludes the aneurysm effectively, reduces periaortic fibrosis as well as renal impairment in most patients. There is very low procedural and midterm mortality with acceptable intervention rate. The Cochrane library data shows that there is no published randomized controlled trial or quasi-randomized controlled trial or any controlled clinical trial comparing EVAR as well as open repair. So it is left to the treating surgeon to decide what is the correct treatment option based on his expertise. Now, a group from Japan have divided aortic aneurysms into two, that is immunoglobulin G4 related and immunoglobulin G4 negative. They have found that they classify cases as in immunoglobulin G4 positive when the level is more than 135 milligram per deciliter. And they have concluded that open surgery is far better in patients who have elevated IgG. Periaortic fibrosis progression is also higher in patients who are positive for immunoglobulin IgG4. And the sac enlargement during follow-up was also a problem in these patients. So the summary and take-home message is there is no randomized controlled trial comparing open surgery versus EVAR in this particular group of patients, that is inflammatory aortic aneurysm. The term is slightly complicated, I agree. I actually discussed this entity with our own professor of radiodiagnosis, and he told he has seen only 2 cases in his entire career. I discussed actually with Professor Unnikrishnan, and he told he has operated 350 cases, and he told he has seen only 3 or 4 cases which fulfill the criteria which is mentioned here. I don't know what is your personal experiences. I have seen only single case that is treated here by surgery. So you have to do screening of IgG in all patients with inflammatory aortic aneurysm. And as they say, if the IgG4 is more than 135 milligram per deciliter, then open surgery may be the better option. Then if IG4 negative, then you have both options, that is EVAR as well as open surgery. But be careful in excluding patients with the renal impairment, that is ureteric obstruction. Don't take such patients for EVAR. If there is hydroureter or hydronephrosis, then open surgery is definitely better. Thank you.
Thank you, Dr. Rajesh. It was a wonderful talk. You have given state-of-the-art information about this entity, which is not so common. Do you have any data from India on this entity, any series, or what is the Indian literature on this inflammatory aneurysms? It is very rare.
Sir, I could not find any reference from Indian literature.
Okay. How it is pathologically different from Takash's arthritis?
Actually, there is extensive fibrosis, and the main difference is the peri-aortic fibrosis that in sharp contrast to the Takash's arthritis, there is often associated retroperitoneal fibrosis. That is the most significant differences between Takash's arthritis and this entity. There is significant retroperitoneal fibrosis.
Yeah, mostly you see the aneurysms, but how often do you see stenosis in these conditions?
Sir, that is not reported. So that is the difference between Takash's arthritis and the inflammatory aortic aneurysm. Both the stenosis as well as aneurysm is seen in Takash's, but not in this entity.
In the medical treatment, the steroids are used or any other drugs are used?
Steroids as well as immunosuppressants. Many use many agents like azathioprine or mycophenolate mofetil, depending upon the institutional policy, and mainly actually that is treated by the rheumatologist. And I have discussed with many endovascular interventionalists, and they told that in their institute, actually George Joseph are told that it is rheumatologists who manage such cases in CMC Vellore.
Is there a role for PET CT to find out the inflammation, image the aorta and see?
Yes, sir.
Yeah, there is.
Yes, sir. Yes, sir. I have shown that picture. But the main problem is you cannot differentiate infectious versus this entity, because PET will be positive in both cases.
Interesting. I have not seen any inflammatory aortic aneurysm. Do you have any experience, sir, that Professor Tyagi? I think you have.
No, that is why I said it is very rare. We have not seen this aneurysms here, particularly in North. But as you said, the surgeons like Dr. Unni Krishnan, etc., have reported some cases. We had a workshop, so we reported some cases of surgery in these types of aneurysms. So, but these medical therapy only reduces the inflammatory markers, or do you have any regression of this stenosis? What does the literature says about it?
Yeah, the literature definitely says that the peri-aortic fibrosis is reduced by around 50%, but it's not a cure. But in 50% of patients, it is definitely reduced.
Yeah. Good.
Sanjay,
any questions from the audience?
Yeah.
No, I think probably we have not looked for it, and I think any aneurysm which presents with pain, if there is an acute enlargement, there would be an inflammation. So I think it's very difficult to differentiate this entity from something which is enlarged quickly. All patients who have a sudden increase in the aortic, because a lot of patients present with abdominal pain, and if you don't treat them, if they rupture, they die, we will not come to know what's happening. So I don't know, but I have not seen any isolated inflammatory aneurysm so far in so many years of seeing both aneurysms of all parts of aorta, but not inflammatory as such. Of course, we have seen a lot of mycotic aneurysms.
Yeah.
But surprisingly, the literature shows that 15%. So I was shocked. So that's why I contacted many and asked what is the incidence. And they all say, majority told they have not seen.
Correct. I agree.
Ashish, where do we stand today with respect to ascending aorta aneurysms? Are we encroaching on surgeon's domain, or what do you think? Is there any specific indication? Yeah, the mid portion of the ascending aorta, yeah, very true, as you said. But as we encroach towards the valve or coronary or the towards the aortic arch, surgeon still takes over these cases. But what do you feel? The evolving technology.
So I think we definitely are. We definitely are actually moving towards ascending aortic endovascular solutions. And the literature says about 30% of these patients can effectively be treated by even what is available now with a lot of challenges, including the Senate Ascent. It should be sufficient to treat focal disease, typically penetrating ulcers in the ascending aorta, pseudoaneurysms, a sequelae of previous aortic cannulation, and selected cases of type 8 dissection. The more complicated ones, so the endoventral is, again, more refinements are in the pipeline, including, internalization of the branch graft so that the device becomes less bulky, and easier cannulation of the coronary ostia. And more importantly for aneurysms, which 1/3 of ascending aortic aneurysms involve the arch as well. We have solutions like, the two-piece graft, which with the fenestration to the left common carotid can provide a complete endovascular solution. But of course, having said that, the technology has to move forward, and that the two-piece graft, I believe, will be commercialized in the coming year. So that is good news for us as well.
What do you think will be the have to happen to the because with endoventral, okay, let us see that the endoventral becomes a a regular routine. What will happen to the coronaries? The natural history of the
exactly. So that is a big concern. That is a big concern because the long-term patency of the coronaries. So conceptually, there is another possibility is to have bilateral, that's mammary grafts to the right and the lemur, and then which will provide long-term patency of the coronary arteries, a complete arterial revascularization, followed by a modification of the endoventral.
Yeah, that appears much better.
More plausible approach as compared to a complete endovascular solution.
Yeah, I also feel the same, that although it sounds very easy for you to sort of put a TAVR valve and then put an endoventral, but the only thing would be you're creating a longer left main segment, risk of thrombosis with a stent in between. I mean, I would be uncomfortable, and how long this is going to last. Our surgeons do at least 2 ventrals every week. For them, it is easy to, take care of it. Although in a dissected patient, I think the choice of just doing the aortic replacement in a type A dissection is not it probably almost about 80% of them come back with some kind of a need for reintervention in a thoracic aorta. And I think that's where the arch and the devices which will take care of the arch as well as the proximal aorta, then leave something for you to do it later as an endovascular specialist would be a good idea. And I think this will require growth of technology in terms of both professionals and those who do specifically aortic surgeries along with endovascular treatment with the help of a cardiologist or a radiologist would be kind of a good answer to all these things.
Then I agree with Dr. Sanjay, but the problem is if you look at what the surgeons have done for a hemi-arch, you find that the false lumen remains patent.
Absolutely.
And aneurysm formation in the long run is a concern.
Absolutely.
So a hybrid approach as compared to a pure surgical approach would be the ideal solution.
So I think the answer would always be that you start using early treatment of a type B dissection, for example, where you take care of the flap in about 2 weeks to 6 weeks time so that it doesn't become very rigid. Obviously, you can't do it so in all these devices, they laminate the flow put a dissection stent. The remodelings have been much, much better. The case reports are only about 50 cases all across the board. Not many, like the petticoat or the stabilizer technique, where you can take care. The false lumen cannot be ignored, especially in type B dissection for a long time for us, especially when the patients are less than 50 years of age. We get a lot of patients where uncontrolled hypertension is causing dissection. Most of our patients actually who come, I have a patient right now, he's only about 54 years of age, who has a dissection, but a type B dissection, going into zone 1. And the true lumen is okay. But then over a period of time, the false lumen will go, true lumen will compress. And if you don't treat them quickly, they will become very, very rigid. The intimal flap, when it gets calcified, you can't move it. So I think the treatment strategy should change. Then you should start treating them early rather than waiting, say, more than a year or so. All these patients, when you put a stent graft into them after 1 year, they have a continued pain for a long, long time because you're not trying. The stent graft is stretching the intimal flap, trying to sort of approximate. I have a patient who continued to have pain for 1 year after I put a stent graft. You don't find anything, just pain. So the treatment of intimal flap, when to do it, is a big question and not known to people.
So Sanjay, that means medically managed type B dissections natural history can change. You mean to say, depending upon the false lumen size, it can either become aneurysmal or it can compromise the lumen and then contribute. And then when you want to treat endovascularly, it will be difficult because it is rigid. That's what you mean. So with that idea, so what are your recommendations for, as on today, for endovascular treatment?
So I try to cover as much as possible, but then as you cover more, you have a risk of paraplegia. That is one important thing. The second thing is that although the risk of paraplegia is pretty low if the aneurysm has become at least 2 or 3 weeks old. But important thing is that we should not ignore the false lumen treatment and the intimal flap approximation. See, we do coronary angioplasty all the time. What do you do when you have a dissection? You put a whole cover. Why not cover the lower part with a bare stent and maintain the flow into the vessels?
Yeah.
And you are done. And this remodel is in the 2 years, you will see the aorta is remodeled itself. And all those patients where the false lumen persists have worse prognosis where the false lumen is not fully thrombosed. If it is thrombosed fully, fine. If it is partially thrombosed, you have a problem. So either you have to create the thrombosis completely, or you need to take care of the multiple entry tear as well. So the technology is coming, or understanding is coming, that you should not have a larger secondary entry tear, because that will lead to enlargement of the aneurysm. I have at least 30 or 40 patients where I have to treat the false lumen again by some technology.
Generally, when do you do it? Yeah. When do you do it generally? So suppose now you have started in medical management type B. When do you do it? Or when do you recommend?
So far, we've been treating when they come and the aneurysm is now becoming 6-7 centimeter in the thoracic aorta. But I think it's a bit late, and I think we should become more proactive in treating them early so that you don't land up in that.
How does the large vessel intravascular ultrasound helps in this management, the fenestration of the flap?
Sir, we are quite expert in doing punctures all across the body. So we can puncture very easily. So what I do is that I go into the true lumen and I confirm by the CT gives me an idea that I'm in the true lumen because I know everything, which vessel is coming. So reading CT is the most important. And you put a catheter in the false lumen pigtail and just direct. You can inject a small amount of contrast and just pierce it. And I put a PTCA wire through that broken burrow needle. And the PTCA wire then goes up, and then I advance the catheter, and then I advance a Terumo wire, and I put or Terumo, or even a Lundquist wire, or a Amplatzer wire, and just put a balloon and enlarge do the fenestration. It is not very difficult for us to do it. I mean, you try it, you'll be able to do it. It's very easy. The skills of Indian doctors are much better than all the Westerners, I can tell you, because we are exposed to so much of technology when we see ourselves. I think you will all agree with me.
Sir, shall I make a point, sir? BC, sir?
Yeah, sure. Go ahead,
See, that is regarding what Dr. Sanjay said. There are two different concepts. all those who have worked with Roy Greenberg, Stephen Halong, Tilo Koblen, all those, they strongly believe that dissection should be repaired completely, and that is using covered stents. So they do it as a 2 or a 3-stage repair. They fix the proximal descending thoracic aorta with a covered stent. Subsequently, they go for a complete fenestrated, which is a custom-made fenestrated or branch grafts for the viscera, and they complete it by extending it to the iliacs. And they strongly believe those groups, Stephen Halong and all those who have worked with Roy Greenberg, strongly believe that use of bare stents is far inferior to the the use of covered stents in dissection, because conceptually itself, we are moving away from what we thought would be ideal for dissection treatment.
So I think if we have time, there's just one more comment that I'm always worried about putting a covered stent in a vessel, which is otherwise, how long do you think a covered stent would last if you have a patient who's 50 years of age? This is my worry for all these things. In the branch vessels, not in the main vessel. Main vessel is fine. Dr. Ashish, what's your thinking?
See, now whatever is published, actually, from basically France, and then from Sweden, Dr. Diaz also has done some work on this. Their results are very impressive. And mostly they use custom-made branch grafts.
Correct.
And if you believe them, it really works. It really works. And they believe you should repair the entire aorta rather than do what the surgeons used to do, just a partial repair of the entry tear, which they believe will not be useful in the long run.
See, unless you become very good, like George has become in creating a branch graft on table, I also agree that the custom-made grafts are better because their inner, alignment and the connections, the stitching is more, a proper flow into these laminar flow. If you have turbulence going on, then you will always have this risk of, causing problems. And I don't know whether there'll be technology where they will dissolve the struts and then they'll make the vessel become completely internalized or endothelialized. And that would be the best thing to happen. But I think the time is not far. It will happen over a period of time. There would be technology available which will match the patient's biological structure.
Friends, we had a wonderful discussion on aorta and the new frontiers in the aorta. And in fact, the subject discussed was a wonderful one. I request Professor Sanjay Tyagi to give his final remarks and we will move on with the sessions.
I think this is a very, all the three speakers did an excellent job, and the lectures were of the state of the art. I congratulate all the three speakers for delivering these wonderful talk.
Thank you, sir.
So thank you. This is from the studio of Narmada studio. Yes, we have now a point counterpoint talk, but the first speaker, Dr. Raman Chawla, is not available. So we have asked Dr. James Thomas to cover both options. So we will give him 10 minutes for his presentation instead of 7 minutes.
Sure, we'll go ahead then.
Dr. James Thomas, please.
Respected chairpersons, seniors, and dear friends, I'll straight away go to the talk. That is, stenting will only be my bailout option in SFA angioplasty in critical limb ischemia. Now, why are we concerned about stenting the SFA? Because there's a beautiful article in circulation that we cardiologists have a tendency to put stent everywhere we poke, and there's an article which remembers us or reminds us that SFA is not actually left anterior descending artery. We have to treat it differently. So what is the issue with SFA? The SFA is subject to so much forces, flexion, torsion, so much forces, so that the chance of having this, that is stent fractures, is very high. And whenever you have stent fractures, you'll have restenosis. So once you put a stent and it restenotes, your options in revascularization becomes very limited. And especially if you have to avoid stents in CFA and popliteal artery because of obvious reasons, because they are hip joint and knee joint and CFA, you can occlude the profunda. And most importantly, in our setup, the cost, because CLA patients have got an economic issue also. So we had to make it cost effective. So I'll try to convey my points with 2-3 cases. So this is the first case, 16-year-old lady, critical limb ischemia, severe rest pain, bad foot, and this was her angiogram. She had a distal SFA total occlusion with 3-vessel BTK disease. And we could cross, we dilated, and this was the result we had. We had a significant dissection. Now, in these type of situations, there is no controversy, because we know that whenever there is a residual stenosis more than 50%, or if there is a flow limiting dissection, we have to stent. So here there is no controversy. So that's what we did. We stented with a super of 4.5 millimeter, and we had a good result. Now we'll go to the two controversial scenario. So next case is 65-year-old diabetic man, again bad foot with severe rest pain. And this is his angiogram. Proximal SFA 70% lesion and mid SFA short segment total occlusion. Again, we could dilate, and this was the result we had. We had a decent result. We had some dissections, but not obviously flow limiting. So what to do in these type of situations when you don't have a flow limiting dissection? You should stent or you should stop here. Here, I would like to impress upon one factor, that is the most important factor in deciding whether to stent or not is the lesion length. And the 2018 ACC guideline very clearly differentiates lesions into two, less than 100 millimeters and more than 100 millimeters. So they have to be treated differently. The basis of this is multiple trials, and especially the famous FAST trial, which compared stenting versus plain balloon angioplasty in lesions less than 100 millimeters. And it's clearly showed that there is no significant difference at 1 year, even in Doppler assessed restenosis, TVR, or Rutherford category, anything. So basically, less than 100 millimeters, there is no difference between angioplasty and stenting. The guidelines also say the same thing. The ACCH 2018 guideline, if it is less than 100 millimeter angioplasty, is an appropriate indication, just as it is bare metal stent. The 2016 ACCH guideline also, that is, if it is the lesion is short, less than 10 centimeter, then stent placement is not necessary. So that part is clear. Less than 100 millimeter, you need to do a POBA only. And the patient, the follow-up, he underwent amputation of his second to fifth toes. His wound healed, and he was pain-free. In the last case, it's a 72-year-old male. He has again bad foot. He had a long segment SFA total occlusion with severe rest pain. So this guy was having a long segment SFA total occlusion in contrast to the previous case. Again, we could cross, we dilated, and surprisingly, we had a reasonably good result with dilatation itself. And that is, there were some dissection, but it was not flow limiting. So what should we do? Long lesion, a reasonably good result after POBA. So do we have any guideline here? We do have guideline, the 2018 ACCH guideline. Here it is not favoring angioplasty. That is, more than 100 millimeter angioplasty is only maybe appropriate, and stenting is actually appropriate. Even in 2018's the SKY guideline, here actually PT and the plain balloon angioplasty is, they say it is not recommended. Actually, BMS has got a class 2A indication, DEB and DES have got a class 1 indication. So what should I do? Should I stent? Do I buy this recommendation? I don't buy this. So actually, I did not stent. I will explain why. And the patient did fine. We had the follow-up. He underwent amputation of his toes. His wound healed. He is doing fine, and there is no pain. So actually, when did the guidelines change? If you see the previous guideline, that is 2005 ACCH guideline and the 2012 NICE guideline, they are very clear. Do not offer primary stent placement for femoropopliteal disease in critical limb ischemia. They are very clear. So what happened after that? Actually, even after this, after the guideline, there have been trials like the super trial, which included long lesions, multiple registry data. We got the Cochrane analysis seen on the bottom of the slide, all showing that the plain balloon angioplasty was almost equivalent to stenting in critical limb ischemia. So what happened in between? Basically, the guidelines actually were slightly taken away by many industry-sponsored single-arm studies of newer stents. Of course, there were no comparators, and they were not real-world patients. But also, there were three important randomized controlled trials favoring the routine stenting in moderate or long length patients. That is the absolute trial, Astron trial, and the resilient trial. But there were some issues with this study. The famous the resilient trial and also the absolute trial. One important issue was the crossover bias. That is, even though the study, the result was that the stenting was superior to plain balloon angioplasty, there was around 30 to 40% crossover from the angioplasty group to the stenting group. And if you take the intention to treat analysis, that is true. But if you analyze based upon what actual treatment the patient got, there was actually no difference between angioplasty and stenting. And more importantly, this is one thing which I would really like to stress, that is, these trials are actually talking about something else. We are actually talking about critical limb ischemia, where there is rest pain, ulcers, gangrene, and tissue loss. But see, all these trials, see the percentage of CLA patient. The resilient trial had 0% of CLA patient, 100% patients were claudicants. The absolute and Astron trial have less than 10% of CLA patient. So basically, they were not CLA trials. They were actually claudication trials. And more importantly, these trials were addressing something else, because they were addressing Doppler assessed restenosis and patency, TVR, claudication distance, etc. But are we really concerned about these? Of course, it is good to have all this, but what is our concern when we are treating a CLA patient? Our main concern is this: limb salvage, amputation-free survival, male or major adverse limb events. These points actually were not addressed in these studies. So obviously, we cannot extrapolate these claudication data trials to our CLA patient. This is also actually acknowledged by guidelines also. The 2016 ACC-IHA guideline is very clear. Most studies were underpowered to assess patient-oriented outcomes like amputation, wound healing in critical limb ischemia. The SKY is also very clear that even though the patency is desirable, once the wound has healed, even if restenosis happens in the limb is not at jeopardy. So that's one important, because CLA is different. Of course, we have great data with drug-eluting balloon, because that is one technology which was definitely found to be superior compared to plain balloon angioplasty. We had multiple trials, the IMPACT trial, Levant trial, etc. And actually, DEB is actually now class 1 indication in almost entire spectrum of femoropopliteal disease. Same with DES also. DES also is also having some good data, and that is also a class 1 indication. But what is the issue? We are all familiar with the drug-eluting mortality conundrum. That is, after this famous meta-analysis, it was seen that there was a signal regarding very high mortality, a late high mortality in the drug-eluting, the DEB or the DES group. But of course, some recent papers have come, which is also highlight the other side of the story. That is, there was not much increasing mortality, and there's an article showing that it may be okay. It may not be as bad as it is. So with this, I'll just conclude with my messages that critical limb ischemia is not actually equivalent to claudication. We should treat them differently. We cannot extrapolate stenting outcome data from claudication trials to critical limb ischemia. And focal lesions, no doubt, peripheral angioplasty, the plain balloon angioplasty itself will be enough without bailout stenting. And we have to remember that the trial data, which favors routine stenting even in long lesions, they don't hold good in critical limb ischemia patients. And my strategy will be definitely bailout stenting because it is cost effective, and there are much more options for re-interventions in case a restenosis happen. Of course, I will love drug-eluting devices, especially drug-eluting balloon, but because of the mortality controversy, we need more data. So with this, I will conclude. That is, in SFA angioplasty in CLI, it is better to leave nothing behind. It is better to leave no metal behind. Thank you.
Thank you, Dr. James Thomas. I think it was a very balanced view of SFA treatment, particularly for the total occlusions. As you had shown in your cases, when there is no flow limiting dissection, I don't think the stenting is necessary. So stent should be avoided if it is possible, unless there is flow limiting dissection, because it does not reduce restenosis except with the drug-eluting balloons and drug-eluting stents. So the when the dissection is not flow limiting, it should not be stented, because as you have rightly said, this segment of the artery, that femoral artery, is subjected to lots of pressures, torsions, and causing fractures in the stents. So the as if the balloon works, why stent? So that is the, I think your message is absolutely correct.
Thank you, sir.
It was a lucid presentation, James. It was wonderful.
Thank
Actually,
you.
even
See you
if
again.
Raman were to be there, Chawla also would have agreed with you that all cases need not be stented. I fully agree with you. But there is definite role for stenting, and especially the newer generation. The supera stent definitely has a better the characters, and then the long lesions, especially the long ones. Probably supera is a better choice. As you definitely showed, the drug-eluting balloons also work. I think in your case, maybe after treating the long lesion, the residual, small dissections probably could be treated with a,
Drug-eluting balloon.
yeah. So DEB is a good choice.
Another benefit of doing the drug-eluting balloons in these peripheral territories is that you can keep them expanded for a long time, so as to allow the drug to elute out from the balloon to the intima media. So it works better. Dr. James, I have a few queries.
Yes, sir.
What is any development in, apart from paclitaxel to sirolimus, any development in the drug-eluting balloons for the
Um,
peripheral arteries?
there are some new studies with sirolimus eluting stents, but actually there is not much data in critical limb ischemia, and especially after the increased mortality issue, the DEB and DES scenario is slightly not very enthusiastic these days. So, what is your practice after this mortality issue? Have you slightly toned down on the drug-eluting technology, or are you still using them?
No, they like drug-eluting balloon technology is still very good. I think you can keep them expanded and you can avoid the stent. So it is much better to get a restenosis in a stented artery than a native artery. If you get developed restenosis anywhere, you can do a cutting balloon, and that would work better and keep it without a stent. And you have to respect the intima. So that is very helpful. Another thing that I wanted to ask you is about the use of the stent grafts in the peripheral femoral arteries or the peripheral arteries. What is your view on the use of stent grafts in the
Stent,
in these this
there are
segment?
some studies with the Viaband stent grafts, but the incidence of restenosis is actually higher compared to a drug-eluting balloon. So it is actually not very widely used, and of course they are not available in. I don't think they are available in India also. That is SFA Viaband stents.
Viaban is similar. Viaban is used, but problem of that is that you exclude the intima, and the chances of thrombosis in the long segment grafts can be
Much higher,
higher as
much higher,
compared to the stent.
and you may
Yes,
cross off many branches also sometimes.
yes. That is another problem with the help of, but they say the restenosis rate is lower with the help of these stent grafts in these territories. But if you can do with the balloon and even drug-eluting balloon, it is much better to keep them inflated, and particularly for critical limb ischemia, where if you are able to revascularize that segment for few months, then the wound heals and continues to remain good for long term.
Yes, exactly.
We have 1 or 2 minutes for summing up from the chairpersons.
Sure. Dr. Tyagi, regarding the stent graft, what you were telling, it's much better for the iliac arteries because that would long last, in fact, single-digit restenosis rates as compared to SF. No doubt,
See,
but less. Right. Yeah.
Iliac arteries anyway don't reach noses. Because large artery, 8
Yes.
millimeter artery, don't reach nose. Even with the balloon and stent,
Yes.
hardly see any restenosis in the particularly in the iliac arteries.
Yes.
And so use of stent graft is limited for developing of any ruptures or in the iliac artery territories. And but down below in the femoral artery, because that long segment stents have higher chances of restenosis, maybe 100 centimeter or more long stand may be having longer stenosis. So better to use a drug-eluting balloon in these situations and leave a native artery and do a spot balloon angioplasty, a spot cutting balloon angioplasty if the patient develops a restenosis.
So I
I
think,
think Dave,
yes.
yeah,
Please continue.
Dr.
Please
Joy,
continue. We have time. Otherwise, we'll wind up this session.
yeah. Any other views, James Thomas?
Nothing, sir, nothing. Basically, in especially in our setup of patients, the cost concern is also very high. So usually the patients with critical limb ischemia usually have limited economic resources. So we try to conserve costs. So cost concerns are also important. So that is one more point favoring rather leaving the patient
Conservative.
with.
Another thing
Yeah,
that
if
to be
only.
remembered in critical limb ischemia is most often it is infrapopliteal, and the multiple and diabetic patient with infrapopliteal disease having stenosis in the multi-level stenosis in the tibial arteries or perineal arteries, causing total occlusion of the flow to these distal foot, causing critical limb ischemia. So that is more of a problem than a femoral artery causing critical limb ischemia, though it is seen femoral artery stenosis developing thrombosis and causing critical limb ischemia.
And also, if you see the pathology of critical limb ischemia, there is a beautiful article in JACC. It is clearly around 70% of patients, the incidence of thrombus is more in compared to claudicants. So it
Yeah.
is, you can probably say that claudication is like our chronic stable angina, and critical limb ischemia is more like the ACS. That is, you got so much thrombus.
Yeah, and another thing is the use of the newer oral anticoagulants in the peripheral arteries along with the antiplatelet drugs may have to reduce the chance of recurrence of thrombosis and critical limb ischemia, like the COMPASS trial. The
Yeah, the molecular dose of
yeah.
ivaroxaban, 2.5
So
milligram.
yes, yeah. So that may be a better option for long-term management of these patients because you are acting at multiple points in this. Uh, Not only antiplatelet but anti-thrombotic treatment also helps to in long-term management. I think it was a great talk, but James Thomas, congratulations, you have
Thank
done
you,
a
sir. Thank
wonderful
you.
job and giving a very balanced view of the treatment of superficial femoral artery occlusions with the help of stents or to avoid the stents. Thank you very much.
Okay,
Thank
thank
you.
you. Thank you,
Thank you,
all the
CSI.
chairpersons, all the experts, and all the speakers. We're winding up this session. Please wait for the next session. Thank you. Thank
Thank
you
you,
all.
Peter.
Thank you all. Yes, friends, I think we had a fantastic discussion and session on aortic disease and also critical limb ischemia. Now coming up is the much awaited National CSA Quiz Final. The Narmada studio is fortunate to host this wonderful and eagerly awaited competition between the premier medical colleges in India. So I think you will be a wonderful experience. There will be that quiz will start exactly at 11:30. Till then, we will have some interest videos for your relaxation. So you relax and enjoy, and then please don't fail to tune in at exactly 11:30 today.
ഓഡിയോ കയറിയല്ലേ ഞാൻ ഊരി പോയല്ലേ ഏത് അത് എഡിറ്റ് ചെയ്താ നീ വീഡിയോ ചെക്ക് ചെയ്തായിരുന്നു ഇത് ആ എന്താ ചെക്ക് ചെയ്യണത് ആ കറക്റ്റ് ഇൻപുട്ട് ഔട്ട്പുട്ട് കറക്റ്റാണ് നോക്ക് സൗണ്ട് ചെക്ക് ചെയ്താ അത് ആവശ്യമില്ല ഇതിൽ ഊരണ്ടർ വെച്ചാ അതിപ്പോ
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
The telescope guide extension catheter pushes past the ordinary, delivering the performance you want for your complex clinical practice. With a thoughtful, deliberate design, Telescope GEC features a coil-reinforced, hydrophilic-coated distal segment contributing to superior deliverability, and a solid round push wire that maximizes force transmitted along the catheter for superior pushability. Our soft TrueFlex tip is made of a soft polymer melted and shaped to precise dimensions, responsively deflecting and providing flexibility. Smooth Pass technology includes 3 components that work together to smoothly channel stents, balloons, and other devices. A tapered distal push wire section, transitioning from a solid round proximal push wire for flexibility. A polymer on-ramp that maintains superior deliverability and channels devices. And the entry port, contributing to smooth device entry and delivery. As PCI evolves, we're delivering the GEC performance you want for your complex clinical practice. Telescope GEC, an extension of you.
I request to all participants to be on mute.
Jabir sir, Dr. Jabir.
Yes.
Team A, the name of the team is not visible.
To see you fully. No, who is? Is it Sergeant?
Yeah, I am Sergeant here.
Yes.
Team B, I can see KMC Kurnool. Team A, the name of the college is not written. Team B, SGPGI is visible.
No, I will tell you. Team
No,
A
it
is
is not
PGI.
visible for the audience. The name of the college, Team A.
Team A is PGI.
Yeah, but
Team B
the
is
word PGI.
no, Sergeant, please listen to me. Team A is PGI. Team B is SDPGI. Team C is All India Institute. Team Good morning and welcome to this CSI National Intercollegiate Quiz Competition 2020. Let us introduce ourselves. I am Dr. Jabir, I am your quiz master, and my co-quiz master is Dr. Ramakrishnan from All India Institute of Medical Science. Our scorer today is Dr. Sibu Matthew. He is Professor of Cardiology, Medical College, Trichur. And let's welcome our honorable judges, Dr. Ragesh Yadav, Editor, Indian Heart Journal, and Dr. Devabrata Roy, Treasurer, Cardiological Society of India. And it's our pleasure to welcome on board Honorable President of Cardiological Society of India, Dr. Mrinal Kantidas, and the President-elect of Cardiological Society of India, Dr. P.P. Mohan. They will flag off the quiz and then we are into it. No, not now, after this.
Good morning. It's a pleasure for me to start the proceedings. That is the grand final of the National Intercollegiate Quiz Competition 2020. I hand over the mic to our scientific committee chairman and president-elect Dr. P.P. Mohan to start the proceeding.
Dear friends, knowledge becomes power when we start using it. So we are going to see that today. So the team with the best brain and the strong heart, let them win. Over to you.
Thank you. Thank you, sir. Thank you, President. Thank you, President-elect. And I forgot to introduce you, Dr. Sajan. You may be knowing. Sajan is from Cochin studio. Sajan has joined us from Cochin studio.
आजा आजा जिंद शामी आने के तले आजा जरी वाले नीले आसमाने के तले.
So we wish every team a victory. Any one of you can win this quiz competition. And now over to Dr. Rama for the rules of the quiz today.
I think Jai Ho to everybody. These are the teams who have made it. And they're not sitting here. They have to go through a lot of hurdles to reach here. And there are nearly around 60 teams who participated in the prelims. And there's an elimination then followed by semifinals. There are two semifinals. The winners and the runner-ups of both the semifinals have made it. And the winner-up of the first semifinals were Kurnool Medical College. I think maybe we'll have the names.
The Kurnool Medical College, Dr. Sheshi Vardhan, Dr. Rajshekar Reddy. Dr. Sheshi Vardhan and Dr. Rajshekar Reddy.
And the runners-up of that quiz was PGA Chandigarh.
PGA Chandigarh is now Team A, Dr. Jyoti Vijay, Dr. Krishna Prasad.
And then the winners-up of the second semi-final were a team from All India Institute of Medical Sciences, New Delhi.
Dr. Ram Manohar, Dr. Sai Krishna Reddy.
And the runners-up were SGPGI, Lucknow.
Dr. Anindya Ghosh and Dr. Anirudh.
And then we had such a tough time in first semi-final. There was a tiebreaker, and we had to do. It was some teams scraped through, and there is a play of luck that happens. So team D, please log out from another login.
There is a second login. Please log out from that.
Okay. So because there is a play of luck that always be there in such a quiz competition, even though we try our best to manage the questions in such a fashion that everything is equitable, it is very difficult to ask 4 questions which are nearly similar. So we took a random lot, the random sequence was allotted, and based on that, PGA Chandigarh will be known as Team A, SGPGA will be Team B, and All India Institute of Medical Sciences will be Team C, and KMC Kurnool will be Team D. This was decided on a random sequence generated yesterday. So, coming to the quiz format, we are having to have a strict time management will be critical. There will be 30 seconds for each question. The first question will be on history, followed by clinical scenario, 1 question each. Round 3 and round 4 will have 3 questions each, where ECG, echo and imaging will be there, followed by congenital, coronary and hemodynamics angios will be there. In the first 3 rounds, there is no negative marking, and there are marks awarded for correct answers only, and there are no passing. Hence, we will take only the first answer. Whatever first answer you are telling will be taken. And in the round 4, the questions will be sequentially passed to the other teams, plus 10 for correct answers and -5 for negative marking, and passing will be next in line. Then it will be followed by the pre-final round with rapid fire of 6 questions of 5 marks each over 2 minutes. And the final round will be the grid with no passing, no negative marks, 10 marks each. So I think we have nearly made around 300 questions over this weekend. 2 semifinals, the buzzers and other things. So we had a lot of contribution from different people. We would like to acknowledge all of them individually. Thank you. And many we may not have missed also.
And let me read out the names of our acknowledgement. Dr. P.P. Mohan, Dr. Givar Sakaria, Dr. Joe Joseph, Dr. Bhubadi, Dr. Naik, Dr. Deepthi S., Satyavar Yadav, Raghav Bensal, and our co-quiz master, Dr. Sajan. So now we are into it. Now we are into it, and we start with a big salute to the best brains of India. Shall we go? Okay. Team A, here is your question.
Before that, I will just marks will be for this. Three clues will be there. If you identify with the first picture, you will get 20 marks. If you identify with the next picture, it is 10 marks. If you identify with the third picture, it will be 5 marks. So, Team A, are you ready?
Team A, are you ready?
Unmute.
Yes.
Unmute yourself.
Unmute yourself. All the others, please keep muted. Now, here's your question. So, this great personality was HOD of Cardiology, All India Institute of Medical Science in 1958, President Cardiological Society of India in 1972.
Sujay Vijay Roy.
Excellent answer. It is Sujay Roy. They scored 20 marks. Sibu, they scored 20 marks. Fantastic. And his famous article of juvenile mitral stenosis. Team B, ready?
Yes, sir. Yes, sir.
Yes. Here's your question. These are the initial tools used by me for the procedure. Timer.
You want the next clue?
Next clue.
The next clue. I worked here for a long time, and my major procedures were done here and demonstrations.
Next clue, sir.
The third clue. This is the procedure which I did first and which made me so famous. Your chance is over. It's Andreas Grundsing. No, did they tell?
So,
Judges? Sir, your mic is off.
I think. Okay, we'll give him 5 marks.
5 marks.
5 marks, give him 5 marks.
5 marks.
So, Team 3, are you ready?
Team C, All India Institute of Medical Science, your question. I have treated this great man.
Next clue.
Next clue. And I received this medal, or the greatest civilian honor of India, in 1961.
Next clue.
I was the chief minister of the state from 1948 to 1962.
Devrata Roy. Sorry.
It is, okay, little taken aback, it is Dr. B.C. Roy. Team D, your question. In my childhood, I had dyslexic problems, and in the adulthood, I became deaf.
Clue. Next clue.
Next clue. I fought for the ban of thalidomide, and I testified in the US Congress, and following which thalidomide was banned in US.
Next clue, sir.
Now you can see me. Tell you, who am I?
So, any other? Your time is up. Any other team wants to answer? There is no marks for it.
Sir, Helen Taussig.
Helen Taussig, correct answer. Helen Taussig is correct answer, but it is only after their time.
No. Anyway, they didn't answer.
All right. They didn't answer.
No marks for anybody.
Okay. Shall we go to the next round? Yes. Next is the clinical rounds. It is the chase. Think fast and run faster.
Has the question come? Yeah, it is on. Question is on.
Team A, the question is on. A 45 years old female presented with history of class 3 dyspnea on exertion and palpitation. Clinical examination revealed irregular pulse, a soft S1, left ventricular fourth-heart sound, and no murmur. You can see the electrocardiogram, angiogram, echocardiogram. What is the diagnosis or most probable diagnosis?
Just have to answer now.
Answer?
I think I'm afraid we can't give it to you.
Huh?
What we are saying.
Amyloid, sir. We are telling.
No, this is cardiac sarcoidosis. You can see a broad QRS complex, intraventricular conduction defect, a prolonged PR interval, ventricular tachycardia, left ventricular hypertrophy, and the basal part of the IVS is scooped out, which is a typical picture of the cardiac sarcoidosis. Next. Team B. So a 28-year-old female who had undergone a cardiac surgery for a cyanotic congenital heart disease 3 years ago. And following the surgery, she developed progressive fatigue, dyspnea, and cyanosis. And clinical examination revealed cyanosis, a saturation of 76%. Normal S1, wide split S2, no third heart sound, no fourth heart sound, no murmur. Here is the echocardiogram. And what's the diagnosis?
Sir, ASD Eisenmenger.
I'm afraid.
She was operated. Now your chance is over. During surgery, what happened was, instead of the two edges of the ASD, one edge was attached to the or tied to the suture to the huge eustachian valve. Now the blood is directed across the IVC into the LA, producing cyanosis. This was corrected with a redo surgery. Next question. Team C, your chance. A 34-year-old male presented with dyspnea on exertion, weight loss, and fatigue. Clinical examination revealed elevated jugular venous pressure, normal heart sounds, a grade 3/6 mid-systolic murmur at the pulmonary area. You have the echo and the CT picture. Timer.
There seems to be RVOT obstruction because of external compression.
Excellent. It's an RVO. Excellent answer. An RVOT compression, external tumor, and CT is showing it, that huge tumor which was found to be a seminoma. Question number 4. Team D, ready?
Yes, sir.
Yes, your chance. A 54-year-old female underwent a percutaneous coronary intervention to the left anterior descending artery 1 month back. Now she presented with dyspnea, low blood pressure, tachycardia, elevated jugular venous pressure, soft heart sounds. History of a low-grade fever for 1 month. Now you can see, this is not running.
Sir, it's not playing.
Yeah, 1 minute. Yeah. Put off that timer.
Soft heart sounds and cardiac Narmada, mostly. The picture is okay, super.
Shall we hold the question for them? 1 minute.
Sir, you will tell them.
You are ready to give the answer?
Sir, tamponade, sir, because of tamponade, picture is seen in the pericardial.
There is a tamponade, but you have to see the picture. You have to see the picture, then only you can give the answer.
Probably perforation into the pericardial cavity. Pericardial, sir.
No, you have not seen the angio. Once you see the angio, I think you'll be able to answer.
We will come back to the question.
So we'll come back to the question.
Yeah, now it is running.
Now it's running. Fine.
So part of your answer is right. There's pericardial effusion. What is?
Infective ectasia, sir. The stent got infected and.
Yes, great answer. It's an infected stent. It's an infected stent which she underwent a surgery for that thing. Infected stent, correct answer. Sibu, 10 marks to team D. Round 3.
So before that we have the scores. Dr. Sibu, please.
Sibu?
Yeah, it's on display.
So after the second round, the marks are there.
So now team A is leading with 20 marks, team B 5 marks, team C has 10 and team D also has 10.
So these are early days yet. I think we'll go further.
Plenty of questions to come.
Plenty of questions to come. So this is the round. It's a triple threat.
It's a triple threat.
So you have an ECG, you have an echo, and you have an imaging. So the question sets is coming to, there is no passing, no negative marking here. So it is the basic investigations in cardiology, ECG, echo, and imaging. So team A, are you ready?
Team A?
Yeah. Please unmute yourself.
Sir.
Yeah.
Yes.
Each question will be 30 seconds. Like. Timer on.
Your ECG.
Sir, atrial fibrillation.
I'm afraid judges, I don't think we can give it to this. Like.
What is the question? Like, we need to know the
Diagnosis.
ECG diagnosis.
It's all diagnosis. ECG diagnosis. Suppose this ECG is given to you. What is
Sir, irregular atrial
No description. You just come to the diagnosis. Description won't give you anything.
I think we'll refer it to the judges. I think we can't give any marks, I suppose.
No marks.
No marks. This is AF with what?
AF with a broad complex. What is it?
Pre-excitation.
Pre-excitation. Okay.
So go to the next question.
Don't get tensed up. You will lose marks unnecessarily. These are all simple things. Analyze properly. Your echocardiogram.
Sir, core triatriatum, sir.
That is the right answer.
Core triatriatum is the right answer. Sibu, marks for them. Next. What is this image? Imaging. Correct answer. You should give the correct answer. What is this type of imaging?
NIRS.
It's not the correct answer. You have to give the full answer.
Try, you are on the right track.
You are in the right track. You just observe it properly.
Sir, chemogram it is. Is it chemogram?
No, I think your chance is lost. It is NIRS. That part is correct, but it won't fetch you any mark. It is NIRS IVUS. That's the latest investigation. You can see the IVUS image. NIRS IVUS. All right. So next team. Your triple threat. Ready? Team B.
Unmute yourself. Yeah.
Right.
You're 45-year-old with COVID-19. Your time starts now.
QT prolongation.
What is the diagnosis? QT prolongation is observation.
Drug-induced probably myocarditis or
I'm afraid I can't give it to you. That's a wrong answer. Any other team wants to answer? Team D is willing to pitch in. You won't get any marks for this.
S1 Q3 T3 sir.
Correct. That is the right answer. It's a secondary QT prolongation. It's a pulmonary embolism. S1 QT T3. There is sinus tachycardia.
The RV strain.
There is a inferolateral strain. Inferior strain is there, and as well as the septal strain is there.
Yes.
Your echo starts now.
Your echo. You have only 10 seconds to go. Come up.
Tricuspid atresia with VSD.
I'm afraid that's a wrong answer. Any other team wants to attempt? No other marks. Definitely no marks.
Sir, Truncus, sir.
Oh, Truncus.
That's the right answer, but you won't get any marks for this. So your last question, the imaging question, identify the diagnosis.
You can have the moving image and you can concentrate on the static image. What's the diagnosis? Maybe one tough question.
TG.
I'm afraid. No,
that
it's
is
a wrong
not
answer.
a correct answer. Anybody else wants to attempt? There is a huge connection between the right pulmonary artery and the left atrium, which is a huge fistulous tract between the right pulmonary artery and the left atrium, which is well seen. The posterior structure is connected to the right pulmonary artery. The entire thing is an aneurysm.
So this is an RPA to LA fistula. Very
RPA
well.
to LA fistula. You can see in the static image. A static image is showing the posterior part.
Okay. So team 3, are you ready?
Yes, sir.
Your ECG. Which SVT is ruled out? That is the question. The question is which SVT is ruled out?
Started in silence, no? PR jump. Sir, AVNRT?
AVNRT is ruled out. No, I'm afraid that's a wrong answer. Here the conduction is, what is happening is 2:1 conduction is becoming 1:1. So then AVRT is ruled out and AVNRT and the atrial tachycardia are possible. So your next question comes here.
Your echocardiography and the other, right, yes.
Timer on. Team C.
Single pipeline madila. Single pipeline madila. అదే కదా సింగిల్ పైప్లైన్ మజిల్ పారాషూట్ కదా సింగిల్ అంటే సార్ సింగిల్ పైప్లైన్ మజిల్ పారాషూట్ mitral valve.
Right answer, excellent.
Your imaging.
Your image.
Sorry.
Fusion. Bilateral. RV non-confident type ఉంది. ఇదేనా సార్ do we have a rolling?
No, just a second.
You don't have to worry about the time.
You can't see the rolling image.
No, just there's some glitch, technical glitch here.
So can you tell me what is present there right now? What is your inference?
Bilateral pleural effusion more on the left side, and we can see pericardial effusion also mild.
You can see pericardial effusion?
Yeah.
Well, yes, sir.
Then what else?
There are some prominent trabeculae in LV. RARV is slightly larger than LALV.
There is pericardial effusion. What else?
There's pericardial effusion, pleural effusion.
And what could be the diagnosis?
Such as probably heart failure.
Heart failure, right answer. That is the right answer. Heart failure. The moving picture was showing an apical hypokinesia. So we wanted an answer of ischemic cardiomyopathy and heart failure. Heart failure is the right answer. We'll give you the marks.
10 marks. So team 4, are you ready? Please mute, team 3, mute yourself.
Your ECG.
Sir, this is, I think they have done some maneuver or given some adenosine, sir, to bring the axillary tract out. There is some WPW side. PR is shortening.
So, how many of you think that he has picked it right? How many in the other teams think that he has picked it right? He is saying adenosine is given to unmask a bypass tract.
There is some 1, 2, 3.
That's the right answer. That is the right answer.
What did he tell?
He said that. Okay. Your echo comes here.
Team D, your echo.
Yes, sir. That SVC and infracardiac TAPVC, sir.
I'm afraid that's a wrong answer.
That's a wrong answer.
Anybody else wants to attempt?
The TAPVC part is correct.
Sir,
no, we can't give it.
The TAPVC part is correct.
Unroofed CS, sir. Unroofed CS.
No.
It is to the coronary sinus.
It's a CS TAPVC. So coronary sinus.
You can see the open coronary sinus. Yes.
Yes, sir. Yes, sir. That coronary sinus, but yes, sir. Okay.
Your image.
Image.
What has happened?
Coronary sinus.
No. That is yours is an imaging question. Can we hold on and we can ask the question later? We'll hold on a question. We'll hold a question.
Hold a question. We'll come back.
One imaging question to you is due. We'll correct it and we'll ask you.
Okay, sir. Okay, sir.
Right. So we'll go to the next.
Sir.
Hello, sir. Yes.
Sir, from Team A.
Are
you going to get any partial marks for the IVAS?
No partial marks. No partial marks. It's only full mark.
Slideshow se bahar aa sakta ho na?
Yes.
You can come out from slideshow.
NIRS was also right.
What?
For our question, NIRS was also right.
What are they telling? I'm not able to.
For the question we have been asked, the NIRS was also right answer.
Judges, nurse is not the correct answer. The nurse IVAS is
the right answer.
Look, nurse anybody will pick up. You have to pick up the IVAS.
So now you can share it like.
Right. Now, what is the diagnosis?
Sir, I can't see anything, sir.
What?
We are not seeing anything. We can't see anything, sir.
No, it's coming. It's coming. Just there's a lag. It's coming. The video started playing.
Now, can you see?
We are also not.
No, sir. Not seeing, sir. The timer is moving, sir. No, sir. No, sir. We are seeing the grid view, sir. Only other teams are visible.
Other teams are seeing it.
Now just share. Now it is seen?
Yes, sir. Now it's visible, sir. Now it's visible. Sir, please make the screen big.
Yeah, now the timer starts now.
Now the timer starts.
This is RV.
There is even an arrow put there, the area of interest.
Sir, there is some mass, sir, where in the LV. There is some mass in the LV which is bouncing front and back.
So your chance is over. Anybody else wants to try?
Thrombus, sir. Thrombus,
no.
Vegetation,
I'm sorry. Your answer is wrong. Anybody else wants to try? It's in the left ventricular outflow tract.
RVOT we can see a floating.
It is a intraventricular septal aneurysm.
Projecting intraventricular septal aneurysm. So we can have the scores now.
Now scores, Dr. Sibu.
We have Team A and Team C. Team A and Team C at 30 points tied and leading.
You use the mic.
Team A and Team C at 30 points leading and tied. Team D 20 and Team B 5 marks.
So I think there are plenty of rounds to go. Now we go to the round which is the curious coronaries, congenital enigmas and hemodynamics where the passing starts. Okay, are you all ready?
So catch me if you can.
Okay, Team 1, your question starts now.
Yes. What is this technique called?
Balloon anchoring. Balloon anchoring.
Yeah, right answer. It is the anchoring balloon technique for passing. You can see the anchoring balloon in the LAD and the stent is being pushed into the
10 marks for them.
10 marks.
Next question, congenital one. No, I'm afraid that's a wrong answer. The question passes to Team B.
Scimitar syndrome, sir.
That is the right answer. It's a scimitar syndrome. where I think the injection is made into the descending aortogram. There is a collateral that is going into the inferior lobe, right inferior lobe, that is draining into the IVC. So they get plus 10, and the team A gets -5 for this question. And your next question, 24-year-old man with heart failure. Your question on hemodynamics.
RA which is elevated है.
Your time is going to end. Or you want to answer or pass? I think I'm afraid you have to pass this question. Question passes to team B. Team B want to attempt or pass? Immediate. 1, 2, 3.
It passes to team C.
C.
Pass. Team D.
Pass.
Okay.
So it's very simple. I don't know why there is so much of confusion. So at times simple ones become very difficult. So it is equalization of diastolic equalization of all the pressures, gross heart failure and low output. So if you have said either CCP or RCM, we would have given it to you.
Somebody was telling about the RA pressure elevation. The LA pressure was almost equal.
No marks for this question. And no marks for the quiz masters also for this question.
No negative and no marks.
So team 2, are you ready? The team from HGPA?
Yes, sir.
Yeah.
Yes, sir.
So what is the abnormality?
Sir, it's not running.
Yeah, just a second.
Sir, timer is already started.
No. We'll
देख लीजिए सर. सुन ले इधर. दोनों साइड का इंजेक्शन. जोर से कोई दिक्कत नहीं.
Not going. I have to come back again. I think I will escape and come back.
Sir, it's not running.
Yeah, just a second.
Don't worry. We'll show you running.
Now it is running.
Not in full screen, sir.
Now it's coming. You can see? Can see now?
Sir, in full screen it would be better, sir. Actually, it is not in slideshow.
It's already sharing.
It is not on slideshow. Not on slideshow, sir. Yes, sir.
So we checked
So
all these technicalities 10 times at least, but still there is a problem. I have to do that again.
You have to do it again.
So this angio you have seen. Next angio, I think I'll have to come out of screen and come back. Yeah, now it is running.
The first one. So what is the abnormality?
Sir, the first one, can you run the first one, please?
No, we can't run. This is enough.
This gives the diagnosis.
It's an intracoronary collateral.
No, I'm afraid that's the wrong answer. The question passes to team C. Answer or pass?
Sir,
pass. Goes to team D. You have to answer immediately. Team D. Team D. Immediate answer. Team A. Otherwise, pass.
Team D, sir. Sir, Axillary LED.
Axillary LED is the right answer. It's team A.
That is, you can see the LED.
Team D, sir. Axillary Team D.
Team D is over. Time is over. You can't answer afterwards. You have to answer immediately. You have to answer immediately.
Sir,
I think judges can refer this, but you can't come back. Like I've already gone to team A.
Sir, no. Sir, actually, team D, you told I was just to unmute, and in the meantime, you went to team A, sir. I'm just unmuting the thing. In the meantime,
I think judges have
the question has already been
passed. I'm sorry.
So the judges have their final say, and the ultimate say from the quizmasters, no mark.
So I think it's an accessory LED. One per team gets -5.
You can see the LED arising from there. From the proximal part of the RCA, the LED is coming along the septum. And in the other view, there was only the diagonal. From the left main, it was diagonal. The LED was not seen. You should look at the septum.
So next question for team B. Identify the intervention. The next is not a still, it's a still image. The one on the right is a still image.
Sir, it's our question.
What? Come again.
Team B's question, sir. This is.
Team B's.
Sir, this is for Team B.
Team B, yeah.
Yes, yes.
Okay.
You have 3 questions. Your time is up. Team C.
BT and dilatation.
I'm afraid that's a wrong answer.
-5.
Team D.
Pass, sir.
Pass. Team A.
Sir, we will take the question. PDS stenting.
I'm afraid that's a wrong answer.
So
this was an obstructed TAPVC with a right ascending vein which has been dilated, balloon dilated.
So 2 minus.
2 minus.
Which
Team
all teams?
A and C.
Team A, Team C, -5, -5.
So your hemodynamic question comes here. Team B's hemodynamic question. Five seconds.
Yes?
Yeah. What Lutembacher? What is Lutembacher? ASD with?
ASD with MSD with MS.
That's the right answer.
Right answer. That's the right answer. ASD with mitral stenosis is the right answer.
Team B. So Team B gets 10 points for this. This is ASD with MS. There is quite a good amount of gradient between LV and LA, and there's a good step up between SVC and RA. So the other conditions that can produce all this are listed here. Team 3, your 3 questions comes now.
Can see the angio? See it in full. It's not over. The history also is there, a history of stab injury to the chest in the past and now in heart failure. Enough clues have been given.
RB. Sir, coronary cameral fistula.
Yes.
Yes. Coronary to where? Like from where?
Where to where? You are right. Where to where? Which chamber?
From RCA to RV.
Wrong answer. It is from the left main to the LA.
Maybe the question will stop here, and maybe we may not give negative mark if judges agree. No marks, but no negative mark. Is it fair, sir? Okay. So no marks and no negative marks for this question.
Next. A 14-year-old with a VSD pulmonary atresia.
Sir, collaterals, coronary to PA collaterals.
That is the, I think that we will give it to them.
Yeah.
It's a PA arising from coronary.
PA arising from the coronaries.
Collateral.
Good answer, excellent. That is Team
C.
Team C, full marks, 10.
So your hemodynamic data set. Timer starts now.
You have 10 seconds more.
You want to pass? Pass.
Pass.
Team D.
Sir, PDA with PR, sir.
PDA with?
Come again.
PDA with?
PR, sir.
No, I'm afraid that's the wrong answer. Wrong answer. Question passes to Team A.
PDA with PH.
No, PDA with PH is wrong answer.
Wrong answer, -5. Last team, your chance. Your chance.
Sir, Team B.
Team B, yeah. Team B, SGPGI.
Sir.
You want to answer?
PDA with LVOT obstruction.
That's the right answer.
That's the right answer.
So there is a good amount of LVOT obstruction that is there. You can see the LV pressures are 130 and the aortic pressure is 80.
That's a gradient between LV and
So
aorta.
it is a PDA with AS. So he gets 10 and there are two teams who got -5.
Sir, we didn't answer.
They didn't answer. There is a issue. I think the team. No.
Yeah, please, Team D, you can be enthusiastic, but you cannot answer it twice. Like that is creating a lot of confusion.
No. What I
So
remember is that they said first it is PS with PDA with PH. Then they changed.
Who answered?
The team who answered correctly initially told PDA with PH.
So who said PDA with PH?
And then they changed it to PDA with
They said
obstruction.
Team D said PDA
No,
with
sir,
PH.
no, sir. We just gave one answer, sir.
Yeah, right.
Team
So
D.
Team D, you will get, next time you do this, you will get -5 for this, please.
So please.
It's creating a lot of confusion because it's online, we don't know who is answering. Please.
Okay, sir. Okay.
So Team A, no negative marks for this.
There are a lot of technical issues. So please cooperate with us.
So Team 4, your question starts now.
So what does one yellow dot represent in this? This is a IFR with co-registration. You can see multiple yellow dots at each point of coronary obstruction. And each represents a particular unit. This is important because this can tell you from where to where you have to stent, and once you stent that area, how much is the residual ischemia. So this helps in a precision PCI.
Pass, sir.
Pass. Team A. Team A. Pass. Team B. Pass. Team C. Team C. Pass.
So it is a 0.01. It is a delta IFR, 0.01 units. Each dot represent. I think they are not exposed to IFR.
So next question to Team D.
Post-operative patient, what's the angiographic diagnosis?
Sir, LA is building, sir, perforation from into the LA, sir.
No, I'm afraid that's a wrong answer. That question passes to Team A.
Question passes to Team A. You have to take it immediately or leave it.
Pass. Team B. Team B. Pass. Team C.
Pass.
Pass.
It's a cardiac arrest.
It's actually a cardiac arrest. The patient is having a cardiac arrest and has a VF after the VT started. This was a patient with Glenn. You can see that there is a PA filling from the LV injection itself. So some kind of single ventricle physiology. And actually after the first BPC, the patient goes into VF. Very rare documentation of angiographic VF. We managed to shock this patient. The patient was hypoxemic, was around 22-year-old. And after the first BPC, patient went into VF. You can now nicely see. So this is your data set.
Hemodynamic data.
Your time starts now.
There is a step up at RV, sir.
Give the diagnosis. Give the diagnosis.
Acha, we need only the diagnosis, sir.
Give the diagnosis.
RSOV to RA, sir.
RSOV to?
RA.
So how many of the teams think that this is the right answer? How many other teams think this is the right answer? That is a perfect answer. That's a RSOV to RA because there is heart failure. All the ED pressures are elevated. So that's the right answer. The other differential diagnosis could be a Gerbeau defect or you can have an BSD with TR. But generally, Gerbeau defect, you won't see such heart failure.
And not only that, your diastolic pressure is quite low. There is a white pulse pressure which tells us that it is a RSOV. Okay, score. Score. Is it the drink break? You can play the music and then we will come back with the marks. No. We'll give 2 minutes, 1 minute. Right, 1 minute for them to relax. Let them relax for a minute.
आजा आजा जिंद शामी आने के तले आजा जरी वाले नीले आसमाने के तले जय हो.
Yes, now Dr. Sibu is here with your marks. Sibu?
Now the box, we have got a tight competition.
Tight competition.
Team A 30, Team B 30, Team C is leading with 35 and Kurnool is 20.
There is an excellent chance for anybody to be winner, anybody to the best in India. It's 30, 30, 35, 20 and lot more questions to come.
So I think we now go to the rapid fire, 6 questions each, 2-minute timer. Now we are going to start with Team 4, Team D.
Team D.
So identify, your time starts now.
Kurnool, it's 6 questions, don't waste time, 2 minutes. It's all timing. Yes, there are questions.
RBOT standing, sir. RBOT standing.
No. You want to attempt again?
Valve in valve, sir.
No, I'm afraid that's a wrong answer. It's a balloon, the melody valve that has been placed inside a stent.
Next.
Next.
Read the OCT. Come, quick, it's simple.
Thrombus, sir.
No,
So,
I'm afraid that's a wrong answer.
Underexpanded, sir. Underexpanded.
Yeah,
We'll give it to them.
It's under expansion. Can we give the marks?
Yes.
Yeah, you can.
Okay.
The judges agree.
Identify the procedure.
Thanks.
It's a tough one. It's done for HOCM.
Sir, alcoholic septal ablation.
No, I'm afraid that's a wrong answer. It's actually percutaneous intramyocardial septal radiofrequency ablation, which has been done through the apex, like with a needle.
Next question.
Next question. What test to use to compare the means of 3 or more independent groups?
What? Chi-square test, sir.
No, I'm afraid that's a wrong answer. It's generally ANOVA.
Student test.
ANOVA is the analysis of variance. I think biostatistics everybody should be knowing.
So you can connect these images with a cardiac drug. You should know the images and the cardiac drug related to 3 trials.
So pass, sir. Next.
It's Andromeda Galaxy, Athena and the Pallas. Now do you know the drug? Dronidaron. And what's this imaging?
You have 15 seconds.
No, sir. Next.
It is CTFFR.
Okay. Next, sir.
Done. Your 6 questions are done. So, I think they got only one right.
Only one right?
Yeah. You got only one right. So next set of things come for Team C.
Team C, ready?
In a patient undergoing TAVR, what is being done?
Sir, cerebral protection device, sentinel device.
Sentinel device, that's the right
sentinel
answer.
device, right answer. The OCT?
Yes, sir.
This is an issue.
So it's not playing.
Not playing, sir. We have a static
Stop
image.
the timer.
No issue. No need to worry. We'll give you time.
Sir, we have only frozen image, sir. Should we attempt on this?
If you want to attempt, you can attempt. Like it's very simple.
Here it's like ISR.
ISR, right answer. Oh, excellent. Even
You saved
without a
us.
moving image, they could answer it. ISR. Excellent. Next. So you saved our time also. Identify the procedure.
Didn't you? Hello?
Yeah.
Sir, we lost connection now.
Hello?
Yeah.
Hello? What is question?
Tell your answer.
Okay, simple, sir. Hello?
Are you able to see or not?
Yes, sir. Now we can see.
No. Hey, Rama, they answered.
You said what did you
Impella. They answered
right. Right answer.
So we'll give you extra time. Don't worry about it. Like what are the things that are plotted in a Blunt-Altman test?
The analysis, sir.
Forest analysis, 1 minute.
Your time is running out. You have more questions.
Next, sir. Next.
Right.
So it is generally the average of 2 measures and the difference between the 2 measures are plotted. So which drug is developed from this?
This you can see the precursor of the drug and the tree, and from the bark of this tree, a drug is synthesized. Your time is up.
No,
Your time.
we'll give them extra time.
You will get extra time.
We'll give them.
Sir, we had some time problems.
One minute. One more question will allow. One more question will allow. Identify the imaging modality.
Sir, fusion.
Yeah, that's the right answer. Fusion imaging is the right answer. But you check. Can you connect to another internet link, because there is a lot of problems in this.
We'll try connecting. Yes.
Rama, this team is having
they got 4 right
connection
answers.
problem.
Sir?
This team is having connection problem.
Yeah, I just told you, sir.
But now if we go and change the connection, it will take time. We lose time. Okay, don't worry. Look, don't worry.
So team 2?
Be calm, be quiet. You are doing well. You are doing well. Be quiet, be calm.
So team 3 got 4 questions right, am I right?
Keep your cool.
Yeah.
And the the bark of the apple tree, you get SGLT2 inhibitors. I could hear you telling SGLT2 inhibitors. Yes.
Okay, team 2, your question starts now, your timer starts now. Identify what is being done along with this TAVI procedure.
So there is a stent being placed in the left main for coronary protection.
That's the right answer because of low-lying coronary. Next question.
The next question.
What is this?
Red thrombus.
It's a calcific nodule. Next.
The pre and post procedure.
A pre-procedure, post-procedure echocardiogram.
The mitra clip.
Right.
Answer.
Excellent.
So this is with the color imaging, like. What are when are non-parametric tests used?
Sir, when the data does not follow a Gaussian distribution.
That is the right answer.
Right answer.
So these are the various non-parametric tests you should be aware of.
Next question, please.
Look, you can see on one side the blood pressure recording which is mounting up. This is the blood pressure recordings of an American president. This was, and it is his death procession. Very famous thing. And at the time of death, his systolic blood pressure was around 300. There were no good drugs at that time. Could you tell the American president?
Pass. Answer then, na?
Pass.
It's Franklin D. Roosevelt. It's such a famous story.
Okay. Next image.
Actually, this brought the importance of hypertension.
Yeah.
In
subcutaneous ICD.
Yeah, that's the right answer.
Next, please.
That's all. Your 6 questions are done.
So how much?
Good.
4. They got 4 right.
4 right answers.
So
Yes.
team 1, are you ready?
Yes, sir. We are ready.
Identify the procedure that is being done.
It is not playing.
No, it's okay.
Tricuspidal implantation.
No, I'm afraid that's the wrong answer. The patient with the DVR who had a valve in valve in the mitral position.
Okay.
Next question. Stent implantation.
A little tougher when compared to the other OCTs.
Biovascular scaffolds?
No, that is not the right answer. That's a partial answer. Partial answer, you will not get the mark because the catch is, I can say the answer. The catch is on the top of the biovascular scaffold, another drug-eluting stent or a metal stent was there. You can see 2 struts. Biovascular stent below and the other stent above.
Identify the procedure.
Next question, sir.
Next question. This was a PTMC with a wire snared out. Many of the trials now report this p-value of interaction. What do you understand by this p-value of interaction? Almost all the trial with tables have this.
The forest plot showing Kappa is better than.
No, it is generally for subgroup analysis. Rather than reporting individual subgroup p-values, you are supposed to report the p-value of interaction nowadays.
Okay.
This is a Mayan Indian, a drug, and the drugs are.
Olnaceron.
Oh, right answer, right answer.
That's the right answer.
Right answer, excellent.
Identify the procedure.
We are playing it or not? Yeah, IVC, association IVC. Huh?
Come on.
Sir, we just did that's it. We are not going to play it.
Your time is up. Please tell the answer.
Sir, we are going to, sir, CAVI. So CAVI.
What?
Caval CAVR.
Yeah.
That's what you're saying? Caval TAVR?
What did you tell? Please come up with your answer.
Team A, come again.
Yes. Yes, sir.
That's the right answer.
That's the right answer.
For a tricuspid regurgitation.
Okay. So now our rounds are over.
This is Team D.
Team D. Shall we come to the scores? And then the grid. Connect to Sergeant.
No, rapid fire. Rapid fire is over. Connect
over. Now connect to Sergeant. You connect to Sergeant. Meanwhile, we'll come up with the scores. You connect Cochin, you can play the music. Meanwhile, the Cochin is being connected. Yeah.
Can
play music? Play music. By the time he can calculate the marks. No, there is one more.
Yeah, next round.
Next round from the Cochin studio.
So next round will be happening from the Cochin studio. So we are getting ready like.
Sergeant, please.
आजा आजा जिंद शामी आने के तले आजा जरी वाले नीले आसमाने के तले जय हो.
Yes, Sibu ready with the marks. Now you have the grid rounds to go. There each team will get four questions. Up till that your marks. Tight? Is there a chance for a tie? Yes, Sibu.
Yes. Now we'll show the marks. Team C is leading with 55 and Team B is a close second with 50 and Team A is third with 35 and D is 25.
Team C, All India Institute of Medical Science, New Delhi with 55 points leads, but just below that or immediately behind them is SGPGI Lucknow, only 5 marks difference, 4 more questions to go for each team. PGI Chandigarh 35 marks and Kurnool Medical College, Andhra Pradesh 25. So still...
We answered 2 questions in rapid fire, so...
We answered, we were 30, sir. We answered 2 questions in rapid fire. Team A, sir.
What is the issue?
Team A, I think we answered 2.
We answered 2 questions in last.
CAVI and Valna, sir.
You have answered correct only 1.
5th and 6th questions. No, 5th and 6th questions.
We answered 2 questions right.
5th and 6th.
Which are the right answers you told?
2. 5th and 6th, they answered 2 right.
2
they
right.
answered 2 right,
Okay.
I'm sorry.
Okay. So Team A with 40 points.
40 points.
So you have improved your chance to win the title.
So anyway, there are 40 marks you can win. So there are no negative marking. So all
40
the best
marks,
to everybody.
each team still has equal chances. 40, 55, 50, 40, 25. Sergeant, connect to
Dr.
Sergeant.
Sergeant?
Yeah, I am ready.
You are ready. Could you start sharing your laptop, please?
Yeah.
Now over to Sergeant from Cochin studio for the grid.
Sir, how much time for each question, sir, in this round?
Sergeant will tell.
30 seconds.
30 seconds for each question.
Same. Please let me know when the time ends so that I can go to the next question.
Yes, sir. Are they sharing your laptop, sir?
Now it's a coordination between you and Sergeant.
Yeah, hi. So we are back with the grid. Since I did not get the grid returns, so I made it grid 2. So let's see. And last time we looked at your school subjects. Now we go back to your medical school days and try to remember all those things that we learned on our journey towards
cardiology. So we have questions for you based on all the subjects in all your MBBS years. So we'll start with team A. You can choose one question and we'll go to that question. Team A.
Sir, before you start, what is the time per question?
Yeah, it is 30, as mentioned earlier, it is 30 seconds per question. There is no passing.
Thank you, sir.
Yeah. Can you please show me the teams side by? Yeah. Team A.
Teams, no need to worry. It's not ophthalmology, gynecology. It's only cardiology related to this
Everything
subject.
will be related to cardiology.
You might have seen the last time the grid. So it is all cardiology related questions, but connections with these specialties.
Yeah. I have my dear friend Dr. Abhilash TG here, who will be helping me with choosing the question. So
where is
team
Abhilash?
A, which one?
I
Yeah,
cannot
he's
see
here.
Abhilash.
He's here.
Invisible
he's
man
known as
today?
yeah, he's the electronic man here. So
Okay, okay.
okay. Okay, team, shall we start? The timer will start only after I finish the question. Okay? Right.
After finishing the question, the timer starts.
Yeah, once I read out the question, the timer starts. Yeah. Team A, you are ready?
Yes.
Yes. So which one do you want?
Pediatrics.
You want to go for pediatrics? Okay. Link and diagnose the pediatric condition based on these images.
Timer.
Time.
Peripheral pulmonary stenosis.
Excellent. You tell me the full pediatric condition.
20 minutes. No issue.
Cardiac condition. Which syndrome?
Alagille syndrome. Alagille syndromes.
Not Alagille.
Noonan's.
It's congenital rubella syndrome. You can see the peripheral pulmonary stenosis. You can see the PDA. You can see the northwest axis. So maternal rubella. So it is a pediatric congenital rubella syndrome. The judges, do we give marks for peripheral PS? Half marks or?
Yes, yes. Judges agree to give the marks. So marks.
Yeah, so 5 marks for team A. So we'll go to team B. Back to school. Team B.
Medicine.
You want to go for medicine? Okay. This is a 40-year-old lady, acute pulmonary edema. She was on ventilator. Gradually her cardiovascular status improved, but we are not able to take her off the ventilator. Later we find that she has diplopia. She is writing and telling us that she has diplopia, and she is having features of quadriparesis. ABG is showing hypercarbia and respiratory acidosis. So we are not able to wean her off the ventilator despite improvement in the LV function. An antibody test helped in the diagnosis, along with a neurology consultation. Luckily, I had my wife to help me.
Sajan, you want the test or the diagnosis of the condition?
The diagnosis. The diagnosis of. An antibody test helped in the diagnosis of.
Unmute. Guillain-Barré syndrome.
Guillain-Barré syndrome.
Which one?
Guillain-Barré. They told it is Guillain-Barré syndrome.
It is wrong.
It's wrong.
Sarcoidosis.
It is. Anybody else want to answer? It's no marks, but you can answer. Guess.
Myasthenia gravis, sir.
Myasthenia
Excellent,
gravis.
excellent, excellent. It's actually myasthenic crisis presenting as Takotsubo syndrome. It's thought to be due to the anti-striational antibodies, one of the mechanisms described. So there are a lot of case reports coming up, and we have to be on our guard when it is difficult to wean patients off the ventilator. And a neostigmine test could be useful too. And anti-acetylcholine receptor antibodies may be positive.
Sajan, we may cut down on the description of answers because we are running short of time.
We'll go back to school. Team C, right?
Ophthal, sir.
It's team C?
Ophthal. Sir,
ophthalmology, yeah.
we have some internet issue, just in case if you can confirm.
Okay, this is an OCT. Dr. Jabir will be happy about the OCT, but this is an OCT of a different kind in a 36-year-old lady with visual symptoms. What is the diagnosis? The eyes are shown along with an OCT image.
In fact, optical coherence tomography we started in ophthalmology only.
Yes, exactly.
ఇక్కడ వస్తుంది చూడండి సార్ సెంట్రల్ లో రావాల్సిన షైనింగ్ సైడ్ వస్తుంది
10 seconds more.
So lens dislocation of Marfan's.
Sorry.
They said lens dislocation.
It's called
That's a wrong
the
answer.
fish eye disease. It's partial LCAT deficiency, less than cholesterol or cell transferase. The OCT is showing hyperreflective stroma of the cornea. Go back to school. It is team D, right? Next.
Gynecology, sir.
Wow, great.
Okay.
Yes, sir, we are great.
This is a 27-year-old lady. It is soon after her delivery. Which drug must always be co-administered along with bromocriptine in this patient?
Sir, anticoagulant should be given, sir.
Excellent, excellent. You get the
excellent,
marks. You get the
fantastic.
marks.
Full marks.
So this is bromocriptine. As per the board, we have to anticoagulate because bromocriptine can increase the
marks
risk
to
of thromboembolism. Go
Sajan,
back to
it
school,
is
please.
10 marks?
Yeah, 10 marks, definitely.
10 marks.
Definitely. Now we go to team A again.
Team A, your choice.
Pathologist.
Pathology.
Pathology. Abhilash, please. What will you expect in the heart of this patient? You are shown images of the liver, pancreas, and lymph node along with some slides, which I hope we all enjoyed during our MBBS days.
You enjoyed pathology, Rama?
Yeah, I feel it's a window to understanding all the disorders that we treat.
Sir,
RCMP.
RCMP, sir, restricted cardiac hemochromatosis, restricted
Excellent, excellent, excellent. So this is cardiac hemochromatosis, iron overload cardiomyopathy. You can see the pearls Prussian blue, and now we rely on MRI and the T2 relaxation. Go back to school, please.
And Sajan, you enjoyed pathology during those days? Great news.
Yes, sir. I had great teachers, sir.
Right, good. We also had great teachers, but the students were not that great.
Okay. Team B, right? Next.
Yes, sir.
Pharma.
Which one?
Pharmacology.
Pharmacology, okay. Diabetic patient with severe triple vessel disease who is having refractory angina. Which drug could be responsible for this ECG?
Sir, ranolazine.
Yeah.
Excellent, excellent, excellent.
Right answer.
So that is
10
ranolazine, the
marks.
QT prolongation, and Torsades, and we also know that it has been given because there was the river PCI trial on ranolazine. Okay, so we go back to school. Which team next? Because I am not able to see the teams.
Team C.
Team C.
Team C. Team C, yeah, please.
Team C.
Make your
All India
wise
Institute.
choice.
Team C, choose your question, please.
Team C.
ENT, sir.
ENT, sir.
ENT, okay, great. A 3-year-old boy underwent an ENT surgery, and these are the specimens, and you can see the histopathological slide.
ENT. Cardiac.
It's an ENT surgery, a very common ENT surgery in children.
Translate, sir.
Translate.
అదే చెప్పండి సార్ ఇంకా ఇంకేం చెప్పారు ఇంకా
Ta-
Tangiers disease.
Excellent, excellent.
Excellent, fantastic
Excellent.
answer. It is
So it is
Tangiers.
orange yellow tonsil in
Great,
Tangiers
great
disease. It's a mutation in ABC1 gene, very low, virtual absence of HDL. Go back to school, please.
10 more marks.
And Tangier is the name of a place, not the person who described it.
Yes, yes, we are here. We are checking it.
Team D, right?
Orthopedics, sir.
Team D, orthopedics.
your option.
A bit of- yeah, Team D wants orthopedics. You can see atrial septal defect.
You come again, Sergeant, please come again. You
It
got
is a short
disconnected.
4th and 5th metacarpal, no ASD,
No
arrhythmia,
ASD,
junctional,
and
the arrhythmias are junctional rhythm, AF 6
Junction
sinus
rhythm,
syndrome.
AF 6 sinus syndrome. There is no ASD. So your obvious answer is not the right
Look, it
answer.
is categorically mentioned, no atrial septal defect.
అదే షార్ట్ మెటాకార్పల్ ఇది కూడా ఉంటారా
And arrhythmias rather than structural heart disease.
You have only 4 more seconds to go. 3, 2,
ఏదో ఒకటి వేసింది సార్
1.
Any other team
Yeah.
wants to attempt?
Somebody else wants to
Anybody
attempt?
wants to attempt?
No marks for this.
Okay, Sergeant, next question.
Okay,
Go back to
we'll
school.
we'll go to the answer.
Yeah.
The answer is Tabatsnik syndrome. It is hand-heart syndrome 2. Hand-heart syndrome 1 is the Holt-Oram syndrome with ASD, while hand-heart syndrome 2 is Tabatsnik with arrhythmias.
So before we
back
go
to-
further, we'll have the scores. Have a look at the scores. We have 2 rounds
Now
left.
we have the scores. Yes, scores
Yeah.
please. Sibu?
No, how Team D has answered?
Team D did not answer.
No,
Yeah.
no marks.
No. What I'm asking is, next question is to which team? Because
Team
I
A,
can't see
Team
that.
A.
Team A. So now it's a close contest.
So AIMS is leading with 65 marks and SGPJ is leading next at 60 marks. PGI Chandigarh is 55 and Kurnool is at 35.
Yes,
Okay,
over to
great.
you, Sergeant. Next question.
Yeah. Now, can we reverse?
Yes, you can reverse.
We'll reverse. We'll start from Team D.
Yes.
Anatomy, sir.
Team D.
Anatomy. Abhilash, please. What specific anatomic variant would you consider in this patient? I hope you can see the ECGs.
Sir, there is axillary pathway, so
Yes.
most likely I'll think for Epstein's only, sir. But P wave is not peaked, but still I'll go with Epstein's only, sir.
Now, I want you to tell me, it's an accessory pathway. What coronary
Short
sinus anomaly will you look for?
Coronary sinus anomaly.
It's on anatomy.
It's up, Sergeant. No.
Yeah, time is up. So the
No
answer-
marks. No marks.
It's a posteroseptal pathway, and we have to look for coronary sinus diverticula, which can be even multiple and contribute to multiple pathways. Back to school, please.
Team C now.
Team C.
ICU, sir.
ICU. Okay. Team C wants to go to the ICU. This 69-year-old male, shock, had underwent ECMO, improved endomyocardial biopsy image is shown. Left side, you can see the patient's CT chest. Right side, endomyocardial biopsy images. What's the diagnosis?
ఇదేంటి ఎలక్ట్రాన్ మైక్రోస్కోపీ
Sir, that is electron.
Yeah. It's electron microscopy. Yeah, correct.
Sir, is it known CAT, a known case of cardiomyopathy in the past?
No. Acute onset. Came in shock.
3 seconds.
There is no discussion. It is
Come again, please. Come again.
Which one?
Giant cell myocarditis.
Giant cell myocarditis.
Sorry.
Sorry.
You can see the CT chest. In 2020, somebody with a CT chest like this, think about COVID. It's COVID myocarditis. This is the first case report of acute cardiac injury with myocardial localization. What you can see the spikes of the viral particle very clearly now, right? So this is COVID myocarditis, first case report.
Team B.
Team B.
Next team B, right?
Yeah, Team B.
Physiology, sir.
What?
Physiology, sir.
Physiology.
Okay. This is a dog experiment. You can see the ECG. Name the effect responsible for this ECG phenomenon before and after saline infusion. This has got application in clinical practice also. Look at the ECG before and after saline is infused. What is the name of the effect?
Post saline infusion, R wave amplitude has increased.
Yes, correct. So what is it called?
Frank Starling.
Oh, you should we give five points?
No.
Or
No,
judges?
They just observed what is shown, so maybe may not be
right.
normal.
Yeah, you can.
Huh?
You can.
Judges are so liberal. 5 marks to them.
5 marks to
Okay,
them.
so judges, we go with the judges. 5
Thank
marks
you,
for them because they noted that
Finding. They
fluorescence
noted the
voltage has
finding.
increased.
They noted
So
the
I'll go to the answer. This is called the Brody effect or the Brody phenomenon. Increased dimension of the, amplitude of the ECG because of the increase in the volume. So now we go back to school. Team
A.
next is
A,
for
Team A.
Team A. Choose well.
After that,
Microbiology.
announce the marks.
Microbiology. Okay.
Score next.
Link and mention the cardiac complication of this disease. It's an documentary is shown regarding this disease. It's got nominated for the Academy Awards. Ten more seconds.
Endomyocardial fibrosis.
Endomyocardial?
Fibrosis.
No. So we go to the answer.
Yes.
It is Lyme carditis can produce heart blocks, and that's the exuded tick. Go back to school, please.
No. Now you can be in the
See the
school.
scores.
We'll come back. We will inform the scores to them.
Score.
4 questions to go.
Yeah.
Your scores. 4 questions to go and your scores.
So it's a tough fight between B The B and C are leading with 65, and team A is 55, and team D is 35.
SGPGI 65, now they are at par with the All India Institute of Medical Science with 65. Tough competition, PGI 55 and 35 Cornell Medical College. 4 questions to go. It is team D, isn't it? Team D, your chance.
Team D. Yes.
Forensics.
Forensic, okay. What is the cause of death? What is the term for this? When prevention depends upon table manners and cure on one's companions. Middle-aged man having food suddenly collapses and dies. Ambulance takes him to the hospital, declared dead on arrival.
What is the term called?
Choke syndrome.
What is the term?
Term.
It is choking, but
what is the term called? It's a particular
it was
term.
a favorite short note during our MBBS days.
Sorry.
We used to get it wrong.
You have 3, 2, 1.
Time is up.
Time is up.
Time is up. It's
Anybody wants to guess the answer?
It's cafe coronary. It's cafe coronary. We used to have so many wonderful answers to this. Okay, so it is cafe coronary, and this is the piece of food that is obstructing and producing asphyxia. Back to school, please.
So I think it's going to be kind of a tiebreaker kind of a thing. Almost it's a last ball. Whoever gets a 6
so
will win
Raman
it.
sir, you can keep the tiebreaker questions ready.
Yeah.
Okay, so team C. Surgery. Yeah. Okay. I want the cardiac diagnosis from this picture, but you have to link these 3 images. You can see what is written also, right?
Last 2 questions.
It's written right testis, epididymis head, left testis, epididymis head, and you have a child and you have a cardiac specimen. I want the cardiac diagnosis.
Sir, is it mumps with endocardial fibrinostosis?
Excellent.
So 10 marks.
It is endocardial
mumps with
fibrinostosis and mumps.
endocardial
Very good. 10 marks to them. We go back to the grid. We have 2 more questions.
SPM, sir.
SPM. Okay, right. So we learn about all the national programs. So I want you to tell me what is Jai Vignan Mission Mode project on which disease? Major ICMR project. This was actually one of the DM entrance questions when I wrote the entrance exam in 2010.
Jai Vigyan Mission.
It's about which disease? Because in 2020 we realized how much community control of diseases is important.
I'm afraid your time is up.
Your time is up?
Yeah.
The answer is?
Rheumatic
heart disease. Okay. We go back to school.
So the last question of this quiz.
Yeah, team A does not have any choice.
No choice, it is biochemistry.
Biochemistry, okay.
Go ready with the marks.
Quickly identify this multi-talented antiarrhythmic agent, which is useful in the emergency room, ICUs, and in the cath lab. Please read. Few more seconds left.
Timer is not on. Why the timer is not on?
Timer.
Timer?
Yeah, 15 seconds now.
Yeah, 15 seconds left.
Amiodarone, sir, amiodarone.
It's not
Wrong
amiodarone.
answer, it is
adenosine, which is used for treatment and for diagnostic purposes during FFR in the cath lab.
So thank you, Sajan and Abhilash. Excellent questions. We have come to the end of the CSI National Intercollegiate Quiz Competition 2020, and I'm inviting Dr. Sibu to announce the marks.
So before that, I think sincere apologies for some other angios not running. We tried our best, level best to keep it technically fit, but somehow things happen like this. Real apologies. Thank you.
Thank you, Abhilash, for coordinating perfectly the movement through the
please, I will call you anyway
so
to announce the winners.
So, Team C has won with 75 marks. Team B is a close second with 65. Team A is 55 and Team D is 35.
So it is All India Institute of Medical Science, Dr. Jyoti Vijay, Dr. Krishna Prasad.
No, I'm sorry.
Is it?
All India Institute.
They are the winners. 75 marks.
All India Institute is Ram Manohar and
sorry. Ram Manohar and Seemal Sai Krishna Reddy. Sorry. It's All India Institute with 75 marks and Team B is SGPGI Lucknow. Anindya Ghosh and Anirudh.
Give them all a big hand.
Yes, big hand, please.
And all of you participated in good spirits. Thanks a lot.
And the third prize is Team A PGI Chandigarh, Jyoti Vijay and Dr. Krishna Prasad. And Team 4, it is Kurnool Medical College, Andhra Pradesh. It is Dr. Sheshi Vardhan and Rajshekar Reddy. Thank you all for the participation. You all reached up to here after defeating large number of excellent people in India. And
Thank you so much, sir. It was
it's
a great experience.
some luck favored somebody. So you all have done well, played well. And congrats to all and congrats to the winners. So I am calling upon the judges and the president of CSI on the stage to announce the result, please.
Congrats
Dr.
to
Ragesh
everyone. You
Yadav,
did well.
editor
Great.
of the Indian Heart Journal, Dr. Debabrata Roy, treasurer CSI, and honorable president of CSI, Dr. Munnal Kandidas. You can announce the result.
I think we have had a very excellent program. In fact, all of you are winners. That's my opinion, because at this stage, actually, when you come over to the grand finale, it means you are something to be reckoned with. Now, I have the honor to congratulate to the whole team who have actually done the excellent work. And second thing is the judges are also there who did their job to contribute to the whole program itself. And really the thanks go to, the most important thanks go to Dr. Zabir and Dr. Rama, Dr. Sibu Matthew, Dr. Mohanan, and Dr. Sajan. So all of them actually they deserve good round of applause. Now again I am going back to the declaration of the result. Team A.
No, it is Team C, All India Institute.
So the first winner is the Team C, that is Ram Manohar.
It is All India Institute. All India Institute.
I'm reading from there. So AIMS New Delhi is the winner.
It's 50,000 rupees cash award.
So
50,000 rupees
50,000 rupees cash award. Then the second team is the SGPGI Lucknow. Again, big round of applause.
They'll get 25,000 rupees cash award. Not virtual, it is true.
The third team is PGI Chandigarh.
It is not a virtual
Again,
cash award.
congratulations. And of course, the fourth team, Kurnool MC, Andhra Pradesh. So I really congratulate all of you. It's a fantastic experience, a fantastic journey you have made. And now any comment from our judges?
I think it was an excellent quiz competition, and I think it is a very new way that they have conducted this quiz. And really, again, I always say that I cannot answer more than 40% of the answers for this quiz. So everybody who has participated has done an excellent job. Sometimes it is a luck that you get a simple question, you get a complex question, but it is a luck, always luck is there in an examination. So congratulations to all the team who has conducted the quiz, and a very, very wonderful, and congratulations to all the winners of this quiz competition.
Yeah, it's a great effort. It's a great effort on part of the organizers, the quiz masters and the participants. And as I was going through the entire event, I am pretty sure of one thing, that we'll have not only good cardiologists for future, we'll have very good teachers also. Thank you.
And the winners, please follow COVID protocol during your celebrations.
Really. But we are going to follow our protocols definitely. Now, as the president of Cardiological Society of India, those who are present in the conference physically, I invite all the would-be fellows, then executive committee members, for being present at the fellowship lunch or presidential lunch, which is usually organized as a presidential dinner, but this year for the COVID reason we are organizing it in the form of a lunch. All are invited in the Imperial Lounge, which is just one floor down. We are standing on the third floor. The lunch has been arranged. They are following the COVID protocol in Imperial Lounge, that is on the second floor. So I invite all of you who are present over here. And after that, of course, at 3 o'clock, we'll be coming for the fellowship program. convocation ceremony program. As usually, it will be done with all the glamours that are associated with the fellowship program. Thank you very much.
And thank you. We appreciate all of you. Congrats to the winners. And
so before that, I think one special word of appreciation for KMC Kurnool. Others are institute people who are exposed to a lot of things, a lot of NGOs and all. Kurnool people coming all the way and being the underdog, performing so highly is fantastic. Hats off to them.
Thank you, sir.
So hats off to all of you. Big salute to all of you. And thanks. Stay safe. Isn't it? Stay safe.
Thank you, sir.
Thank you.
Thank you.
Bye.
Thank you,
We
sir.
are signing off.
Leave the product. Pura leave the.
Okay. You satya.mail.com. I satya.mail. This is the way how you have to. I satya.mail.com.
না না মিটিং এ ঢোকো এটা তো
A very good afternoon to you all. We had a very vibrant quiz session. I am Dr. Anil Balachandran from Narmada Studio, Kochi. I will be the anchor for this session. After a very colorful quiz, we have another vibrant session. I know this is the lunch time. We have an exotic menu with some exotic interventions. The title of the session is Keys to Different Locks. The chairpersons for this session are Dr. Diman Kali, Dr. Prafulla Kerkar, and Dr. Surya Prakash Rao. And in the expert panel, we have Dr. Shiba George, Dr. Vasanta Kumar, and Dr. Dilip Kumar. Welcome, everyone, and over to the chairpersons.
Very good afternoon to all of you. And I believe it's a sunny, bright afternoon in Ahmedabad too, with a very good weather. So today we are going to have a very exciting session, and the time is very limited. So I would call Dr. Shomit Dani. He's a very good friend of mine and a very bright cardiologist, I must tell. And everybody knows him. He doesn't need any introduction. And I have fellow chairpersons, Dr. Praful Kerkar. So can I ask Dr. Kerkar to have his short comments? Praful, are you there? I think he is not there. So can I invite Dr. Shomit Dani to give his lecture on TAVR, how to select the patients? Shomit, please.
Am I audible now? Am I audible?
Yes, sir, you are audible.
Okay. All right, then. I will go.
And your slides are well visible too.
All right, great. So I'm going to talk about how we select the patient for TAVR. The pathway of the talk will be an introduction. Why do we need to select the patients for TAVR? Anatomy and classification of thoracic aorta, different pathologies affecting thoracic aorta, because this knowledge and this information is necessary to select the patient, and then pre-operative risk assessment, patient-specific indications for TAVR, and anatomic considerations for TAVR. The thoracic endovascular aortic repair, or TAVR, is a minimally invasive treatment modality that has revolutionized the treatment of thoracic aorta pathology.
Yeah, I think
Now TAVR is preferred treatment option for type B dissections, intramural hematomas, penetrating aortic ulcers, traumatic aortic injuries also. Now, why do we need to select these patients? TAVR serves basically a palliative purpose. By itself, of course, it does not cure atherosclerosis. Rather, it serves to mitigate its effects and limit its manifestations during the remainder of the patient's life. However, in view of the cost constraints, we must assess the potential benefits with TAVR against alternative strategies. And we perform these procedures in those patients who will benefit from the procedures really well. The ability to undergo successful TAVR is highly dependent on favorable anatomy and being within the criteria for the endovascular devices instruction for use, or IFU. So pre-op imaging and measurements and assessment is vital to determine the suitability for TAVR. So we must know the anatomy. Thoracic aorta, its anatomy and classification should be well known before we begin TAVR procedure, before we begin treating the thoracic aorta pathology. The thoracic aorta is divided into aortic root, ascending aorta, arch, and descending aorta. The spinal cord branches also should be well known to the operator, and anatomic arch variants, bovine arch, arterial lusoria, aberrant left subclavian artery, or thyroidema branch, variations in the origin of the vertebral artery, all this should be well known. And the type 1, type 2, and type 3 arches are also very essential for the knowledge. We also should know the aortic zone variations. What is zone 0, what is zone 1, 2, and 3. And zone 2 is the segment that includes the left subclavian, that should be remembered. Now, if you operate on aortic pathology, thoracic aortic pathology, or any aortic pathology.
Technical team, can you take care of the audio, please? There is some intervention.
Yeah, I think there is a parallel session going on.
Yeah, Shomir, you continue, please. Yeah.
Okay, so these zones are very important because in reporting and in documenting the procedure, these zones are very important. What are the diseases affecting thoracic aorta? That is a pathology of aortic syndrome which you are going to treat. That is also very important. Acute aortic syndromes are very important to know whether it is dissection, whether it is intramural hematoma, whether it is mycotic aneurysm. Diseases causing other diseases like chronic atherosclerotic disease causing thoracic aneurysm, vasculitis and inflammatory diseases, aortoesophageal fistula, coarctation, all these pathologies must be known very well. We also must know the natural history and rupture rate of thoracic aortic aneurysm if it is untreated or if it is treated with medical management. Vis-a-vis also, we should know what will happen if they undergo surgical repair or TEVAR. So we must know that 40% of the TAA patients who do not undergo surgical repair, they die of rupture, and the mean survival has been less than 3 years, and 5-year survival for patients with a 6 centimeter aneurysm diameter is 54%, with a risk for rupture around 4% per year, and risk for death around 12% per year. COPD and CKD are again risk factors for rupture. Once you know the basics, then as soon as the patient comes, you have to assess the risk. And pre-op risk assessment for a TEVAR can be subdivided into 3. Generalized risk stratification, which is done with cardiopulmonary exercise testing, if the patient can exercise, of course. 2 most significant variables affecting cardiac complications. One of them is anaerobic threshold. Second one is open repair. Complications can be predicted by an anaerobic threshold of 10.1 ml per minute per kg. Pulmonary, renal, gastrointestinal, infective, cardiovascular, hematologic, pain complications. All the complications are more when you have low anaerobic threshold. Another very important factor is frailty. Many different frailty index scores are available. However, none has been validated in context of TEVAR, but it is generally accepted that more frail the patient, more the risk of TEVAR and less likely the long-term result to endure. After generalized risk stratification, second thing is system-specific risk stratification, and that is done by specially testing cardiac system, pulmonary functions, and renal functions. It is important to know the ejection fraction, exercise time, if it is available. If it is more than 4 minutes, it's a good prognosis. Dobutamine stress echocardiography can be used, or coronary angiography. Pulmonary functions like spirometry, ability to lie flat, patient suitability for general anesthesia, and if necessary, pre-procedure physiotherapy is very important. Renal function also is very important because if eGFR is low, the patient does not do well in long term. And especially if kidney is at risk during the procedure, you need to perform detailed investigations. Third thing which is important is to know the risk scores. Now there are many risk scores available, and the 2 most commonly quoted are thoracic endografting operative mortality risk score, which assigns a score of 0 to 30 based on 10 variables. The low risk, moderate risk, and high risk, and 30-day mortality for low risk patient is 1.3, moderate risk patient is 6.6, and high risk patient is 24% respectively. Another risk score is developed by Hu et al., they assigned a score of 0 to 6 based on the number of risk factors present, and the scores of 0 to 6 produced 30-day mortality rates from 1.33% to 38% or so. These risk scores, though validated well for TEVAR, they are hardly ever used in clinical practice, and that is something which I must tell you. The most important aspect for anatomic consideration is imaging, and CT aortogram is one of the most important imaging technique for aortic pathology. Thin cut, less than 1 millimeter CTA with arterial venous phase is the diagnostic test of choice, and it is important to identify several factors. Most important factors are, one is landing zone length, because an ideal landing zone creates the best opportunity for good apposition of the stent graft, which allows a good seal and fixation, especially when you are treating dissection. You also must make sure that there is proper proximal landing zone, because that is what is responsible for endoleaks, bird beaking, device migration, etc. An ideal segment of healthy aorta is to be identified. You must identify a relatively healthy parallel aorta with a uniform diameter over the straight segment of the vessel designated to be the seal zone, and it should be non-aneurysmal and free of intraluminal thrombus, calcification, and tortuosity. The landing diameter is important because with commercially available devices, they have their limitations, and it is sometimes not feasible to treat aortic diameters beyond certain level. So if you have a 45 or 46 millimeter aortic diameter, you may have problem in finding the right device. One of the most important factor is tortuosity or angulation, because that will cause bird beak configuration or type 1 endoleaks and will not allow the proper sealing. Calcification and thrombus is another factor. And you must know your statistics of open repair versus TEVAR versus medical management. We must know that TEVAR, what is the 5-year survival rate, and what is the risk for rupture, and what are the recommendations in asymptomatic patients. The only absolute contraindication to TEVAR is an allergy to the device material. And the relative contraindications include unsuitable vascular access, lack of appropriate landing zones, or systemic infection. And this is very important. So when you are selecting your patient, you have to select, especially when you are starting out, you have to select a good patient who has good long-term prognosis. There are certain controversial settings in TEVAR, and that is the young patient, where you can debate whether to do open repair versus endovascular repair. Uncomplicated type B dissection, where you can debate whether to continue with medical therapy versus TEVAR. Things like primary adult coarctation, again, open repair versus endovascular, or connective tissue disorder, mycotic aneurysm, or when you are having a purely palliative procedure, you can debate whether there is a role of TEVAR or not. Take-home messages in selecting the patient for TEVAR: estimate the long-term result of TEVAR versus surgery versus medical management in a given patient. And for that, you need to know natural history, the clinical presentation, and the pathology. Estimate the acute risk of open repair versus TEVAR. You must make the generalized and system-specific pre-op risk assessment, and you must know the risk scores. Check the technical complexity of TEVAR. For that, you need imaging and anatomical consideration. And based on this, you select your patient for TEVAR with a good long-term prognosis. Thank you.
Thank you, Dr. Shomit Dani, for your brilliant speech. We are already over the time, so I would request the next speaker, Dr. Shottamurthy, for his speech on tips and tricks of septal ablation. And I'll have to be excused, like Dr. Proful, I have to join the EC meeting at 1:30. So, Dr. Shiv, if you kindly take the mic.
I'll hang on for this talk, and then I will join. Okay.
Yeah,
Go ahead,
sure.
Dr.
I'll also do like that. Yeah.
Dr. Satyamurthy, please go on.
Yeah.
We need no introduction from Chennai. A very senior interventional cardiologist will speak on tips and traps of septal ablation with alcohol.
Can you hear me?
Yes, very well, loud and clear.
Thank you, Praful. The task given to me is to discuss the tips and tricks of alcohol septal ablation. First of all, we should know the indications of TASH, that is transfer the percutaneous alcohol septal ablation for hypertrophic cardiomyopathy. Patients of NYHA class 3 and class 4 symptoms, there should be at least 30 millimeters resting gradient, or on provocation 60 millimeters gradient. Patients above 16 years are better because one doesn't want to give an infarct at a very young age. History of recurrent syncope. Symptomatic patients, despite of prior myectomy or DDD pacing, and patients who are unsuitable for surgical myectomy because of comorbidities. It was almost started quarter century back by Ulrich Sigwart in 1995. Same year in Germany, it was started by Dr. Kuhn et al. It involves in using two femoral arteries, or one femoral and one radial, and one femoral vein. Femoral vein is used for putting the temporary pacing, either for continuous or standby. And one catheter will go into the left ventricle. The other arterial route is used for putting the guiding catheter in the left main. Continuously, one should keep monitoring the LV and aortic gradient. If patient is getting ectopics, or one can induce ectopics with the temporary pacing wire. 70 to 100 units of heparin is always used. The selection of the first septal perforator is the key, and we always use the anatomic approach, and always it is echo guided. As I said, first septal branch is the key. When once first septal need not always come from the LAD, it can come from ramus or diagonal, or rarely from posterior lateral branch of the RCA. It should be at least 1.5 millimeter size. One or two septals should supply the septum, interventricular septum, and it should not go close to the LAD, that is towards the apex. It should be away from the apex. Then once I'll come to the other 2 points when I am showing the angio. We always use the over the wire balloon. The usual 0.014 guide wire is used, over which we pass a over the wire balloon. Then we remove the guide wire, inflate the balloon. When once we inflate the balloon, we inject contrast to check whether we are in the appropriate septal branch. After confirming, alcohol is injected 2 to 3 ml. The best results are when you inject below 2. Above 2 ml, when you inject, there can be the incidence of complete heart blocks are high, and one may need permanent pacemaker implantation. First, we have to give half of the alcohol. That is about, if you are, see, the rate is like that, 0.1 cc per 1 centimeter of the thickness. If the septal thickness is 24 millimeters, that means you have to inject 2.4 ml. Half of it is injected in the first time. Then every 2 minutes interval, you have to inject 0.2 like that, giving 2 minutes gap. At the end, we have to inject 2 ml and wait for 2 ml. After that, before we deflate the balloon, at least 5 minutes, we have to wait. Then we have to take a check angio. Then there are multiple septals like this, which are less than 1 millimeter size. It is not a suitable anatomy. One should not proceed for that. This is a classical septal branch. It is not going towards the apex. And there is something called milking effect. When you inject the contrast, the vessel gets squeezed. Then once we inflate the balloon and remove the wire and inject the contrast, we inject the contrast to see that there is no seepage of the contrast or backstreaming of the contrast into the LAD. That is number one. Then number two, we see the supply of these septal branches. Third, the contrast should not get washed very fast. That indicates there are multiple collaterals, or there is a fistula between the septal to the RV or LV. Last is when we inject, when we are doing the echo, the right side of the septum should not get opacified. That indicates there is a very high chance of interventricular perforation when we inject the alcohol. After injection, after 5 minutes after the removal of the balloon, when we test the septal, that will be totally closed. Sometimes it may get opened slowly, but the distal parts of the first septal will not get opacified even at the end of 6 weeks or 3 months. The most reliable is that to see the post-ectopic gradient, that is what is called broken Burroughs phenomena. The same thing should be checked after post alcohol ablation, and it should not be more than 20 or 30 millimeters. At least there should be 50% reduction in the gradient when you do the alcohol injection. In the echocardiogram, you will find a classical scooped out interventricular septum, like ice cream scoop. You have scooped out the part of the septum that indicates that you have done a proper job. The temper pacemaker is usually kept for 48 hours. One can discontinue beta blockers or calcium blockers if the patient is already on. Nowadays, we give low molecular heparin at least 5 doses after the procedure because we created a controlled infarction. 2 to 3 days monitoring in ICCU. Then either you can do telemetry or bedside monitoring in the ward. We do pre-discharge ECG, echo, and on the 7th to 10 days, patient can be discharged. If patient doesn't develop complete heart block within first 72 hours, he is unlikely to develop complete heart block. So in such case, you can do a Holter monitor before discharge. The conduction abnormality is expected is RBB is the rule, at least in 50% of the patients. If patient has got prior left bundle branch block, always better to put a DDD pacer before attempting for a alcohol septal ablation, or during the same procedure after alcohol septal ablation in the same setting, better to implant a pacemaker. The transient AV blocks are known in almost 60% of patients. 7 to 10% of patients need permanent pacemaker. Ventricular arrhythmias in 2.5%. If there is seepage of the alcohol into the LAD, one can develop severe spasm and massive infarction. Ventricular septal perforation is very rare complication. If the right side of the septum is opacified when the contrast is injected, that is most likely to develop VSD, so you should abandon such procedure. Rarely there can be rupture of papillary muscle or papillary muscle dysfunction. We got experience with 53 cases, and we followed for a maximum of 8 years, which we published in Indian Heart Journal. The left ventricular outflow tract gradient was almost 80 plus minus 35. Immediate post-procedure, it came down by almost 60%. At 8 years follow-up, 18 plus minus 3 is the LV outflow gradient. It usually shows biphasic gradient. When you put the balloon and inflate it, there should be at least 1/3 to 50% of the gradient should fall. That means you are in a proper septal. Then when you inject alcohol, the gradient may come down only to raise again after 48 or 72 hours, but best results are found at the end of 3 months. This is what is called biphasic response. Initial outflow gradient will come down, again it will rise, and at the end of 3 months, the gradient will totally come down because there is the septal remodeling occurs. In our series, 90% was the procedural success. 2 patients in hospital mortality, one had CVA, the other had transient complete heart block who refused permanent pacemaker. We had 2 late mortality. One patient had prosthetic valve endocarditis. Once he had MR and endocarditis, it was replaced at a different hospital. He came back with prosthetic valve endocarditis fungal, and he succumbed to that. One patient had interval MI. 2 patients had permanent pacemaker implantation. One patient had VT and VF in the ICCU, which was cardioverted, and he was kept on Emedron. So TASH is a safe procedure, and for patients with significant left ventricular outflow obstruction who are medically refractory to optimal medical treatment, including disopramide. TASH is a safe procedure with excellent immediate and long-term results. Thank you for your kind attention.
Well, thank you so much. That was an excellent talk. I don't know, we have to do the discussion at the end of it, is it? So,
sir, we have one more talk.
Yeah, so let us call upon Dr. Lijesh Kumar to speak on interventions in malignancies and how good the catheter can be. Dr. Lijesh Kumar, please.
Thank you so much, sir. my slide seen, sir?
Yes, very well, and you're very well audible. Please go ahead.
Thank you so much, sir. First of all, let me thank the organizers for inviting me and for conducting such big conference, such big scale in such difficult times. I've been listening to the lectures since today morning and mighty impressed with the organization and the conduct of the conference. So big congratulations to organizers. So this is my topic that I was given. I'm an interventional radiologist. I work in Rajagiri Hospital and Lisi Hospital, and we work closely with the teams of Dr. Ronnie Matthew and Dr. Ramdas Naik, sir, the cardiologists in our hospitals. And this is a topic, interventions in malignancy. The catheter, does the catheter do some good? And the answer is a resounding yes. And at the outset, let me pay homage to Dr. Charles Theodore Doctor, the father of interventional radiology. The first ever catheter-guided intervention was done in 1964 by him. And this was the intervention that paved way for all the other intervention subspecialties and specialties that came later on, and many specialties built on what he did at that time. So we, at present time actually, the catheter is a present day scalpel, and we interventionists are the present day surgeons. And there are many areas in which we do things that the normal surgeons cannot do. And these are some of the interventions that we do in oncology. And interventional oncology is actually a very well-established subspecialty of interventional radiology. And there's a big society known as Society of Interventional Oncology. We're all part of it. And they conduct the INN conference. The next conference is on 3 to 6 February 2021. In oncology, we as interventionologists are involved right from the outset in diagnosing by taking the samples for histological examination. We are involved in preoperative embolization and other procedures to make the patient fit for surgery. In controlling disease spread with ablation and chemoembolization, we are directly involved in curing the disease or controlling the disease. And then we are involved in managing the tumor-related complications and the last and but very important in palliative interventions in relieving the symptoms to make the last few days of the patient very comfortable. First, coming to preoperative procedures, let us discuss some case scenarios. This is a 50-year-old male patient with distal CVD cholangiocarcinoma. This common bile duct cholangiocarcinoma. He was in jaundice, which was 25 milligram per deciliter. He was an operable candidate, but with this high bilirubin, he is not a surgical candidate. So in this scenario, the gastrosurgeons are the hepatic surgeons. So what they do is they send the patients to us or the endoscopist to relieve the biliary obstruction. And the patient was referred for percutaneous transhepatic biliary drainage. We punctured the liver, took a catheter across and put a 10 French pigtail. There's a catheter confined the bile duct location. And we are placing a 10 French in external drain to reduce the bilirubin. And after 1 month, the bilirubin has come down to 1.2 milligram per deciliter, and a very good surgical candidate. The planes were normal. There was no distal sway, and the patient was post with ripples. But something happened that changed the course of the patient's life for worse, and that we'll discuss in the next set of interventions later. Next case is a 50-year-old male patient with back pain for the past 6 months. Patient already undergone spine fixation for a highly vascular L1 vertebral body tumor causing vertebral compression, spinal cord compression. And there was recurrence of symptoms, and the patient had come back again with bilateral lower limb weakness. And he was referred to us for preoperative embolization because of highly vascular nature, and which prevented them for doing a proper surgery in the first sitting. So this is an MRI showing spinal MRI and the cath lab angio and the DSA image showing the vertebral fixation device, and you can see L1 vertebral collapse here. And this is a lumbar artery angiogram showing dense blush in the vertebra. And in this case, actually, due to highly vascular nature and multiple supplies, we proceed with a combined intra-arterial and percutaneous embolization. Intra-arterial, we embolize using PO particles, and percutaneous, we embolize using lipidol. And the patient was taken for debulking of the lesion and further fixation. And they could do that with minimal blood transfusion. Actually, I think only one blood had to be transfused with highly significant reduction in vascularity of the tumor. Next is a 60-year-old male patient with type 3A hilar cholangiocarcinoma. The patient had a small left lobe with fusal liver element of 20%. And type 3A hilar cholangiocarcinoma means that tumor is predominantly involved in the right side of the liver. and right side being the bulky part. Many often when you pose the patient for right lobe resection, not much of the liver is left behind for the patient to survive till the liver regenerates. So in these cases come to us for portal vein embolizations, and we took him up. We puncture the liver, enter into the portal vein. There's a catheter inside. We embolize the right branch of the portal veins with PV particles in this. And this is in this case we embolize using lipidol. And after 1 month, in this particular case, FLR had improved to 30%, and the patient was a surgical candidate and was taken for right hepatectomy. Next set of interventions is controlling disease spread with ablation and chemoembolization. In this particular set of interventions, we directly deal with certain tumors in which interventions have a curative potential, and and one of the most common interventions we do is in the case of hepatocellular carcinoma. And hepatocellular carcinoma in cirrhotic patients, we are involved from stage 0, that is very early stage, to stage B, that is the intermediate stage. And since we are dealing with catheter-based interventions, we'll talk about stage B, that is transarterial chemoembolization. It is a level of evidence 1 based on 2 RCTs and multiple meta-analysis. And the arterial interventions in intermediate stage CC consists of transarterial chemoembolization, and there are 2 types, lipidol TACE and drug-eluting bead TACE. There are, although some papers say that DEB TACE is slightly more efficacious than lipidol TACE in larger lesions, still the jury is out on that. And then there are TACE with technical modifications. Let me just tell you something about TACE. In TACE, what we do is we super selectively select the arterial branches of hepatic artery that is supplying the tumor, and we inject chemotherapy, either mixed with lipidol or mixed with drug-eluting beads, and then we embolize that branch also. And TACE with technical modifications involves transarterial chemo infusion, in which rather than just embolizing and come back, you infuse. Then there is transarterial radioembolization, in which instead of chemotherapy, you inject yttrium Y90. And there are pluses and minuses of all the procedures. So just one case scenario, a 70-year-old male, cirrhosis on regular follow-up outside. He was child A cirrhosis. He was referred for treatment of 2 HCCs directed on outside CT. And there was a 7 to 7 centimeter lesion on right side and a 4 into 4 centimeter lesion on left side. And the right lobe lesion, because of size, we took him for TACE. And this is a branch that is supplying the tumor. And we embolize that. You can see lipidol deposition here. This is the DS image post-embolization. And you can see the embolized vessel. And after 4 weeks, CT was done. No resolution was seen in the right lobe. And the left lobe lesion we took for ablation. This is the right lobe dense lipidol deposition. And this is a left lobe lesion exophytic but in the stomach. We ablated that using radiofrequency ablation. And you can see a completely ablated tumor. Nowadays, actually, more and more what we do is for large lesions, is a segment 8 lesion, this lesion. And because of size concern and high AFP, the tumor was very aggressive. We did a combined procedure. We did TACE of the lesion, there's a lipidol deposition, and then we ablated after 4 weeks to get very good results. Next, chemoembolization, it's not just limited to hepatocellular carcinoma. It has a role in liver metastasis, example for colorectal metastasis and neuroendocrine tumors. It's done in bronchogenic carcinomas when there is metastasis, high-level metastasis is there with compression of the bronchi to relieve the pressure symptoms. In retinoblastoma, it has a role in children. It's a very common, it's a very debilitating disease with enucleation, the only definite treatment modality. But when it is bilateral and you have to choose between complete blindness for the rest of the life and a therapy that has good results, many times we choose to do chemoembolization through the central retinal artery. The chemoembolization agents use melphalan, topotecan, and carboplatin. Next set of interventions is managing complications of malignancy. This gentleman actually had prostatic malignancy, advanced, very advanced, not time defining treatment. The patient had come with bladder outflow obstruction, and he had bilateral VU junction obstruction, and the patient had altered renal parameters. The urologist tried to retrograde stent that, but they couldn't because of the extensive tumor burden. And so we were called in. What we do is we puncture the kidney, take a sheath inside with the catheter and wire, cross the lesion, put in a ureteric stent and put in a PCN. And after a few days, we can remove the percutaneous nephrostomy and the patient is on the ureteric stents. And in this particular case, his renal parameters stabilized within 2 weeks, and he was then taken for chemotherapy. Not chemotherapy, radiation therapy and hormonal therapy. This is a case of hepatocellular carcinoma, ruptured hepatocellular carcinoma right lobe. In this case, what we do is we super selectively select the branch supplying the artery, we embolize that. And in this case, particular case, the liver function was good. So we did transarterial chemoembolization. When the liver function is bad, we just plan embolization. This is a case of a 6-year-old female who had chest discomfort, and she was directed to have segmental pulmonary embolism and bilateral DVT. On further evaluation with CT scan, we found extensive retroperitoneal lymphadenopathy, and the patient was started on anticoagulation, but on anticoagulation, hemoglobin dropped, and the anticoagulation had to be stopped. And the patient was referred to us for IVC filter placement. You can see the distorted IVC below the right renal vein because of the compression from the extensive lymphadenopathy. In this case, we place IVC filter. Post placement, there is tilt here. So we know that retrieving this will be slightly difficult if it is impinging on the wall. But then this patient already had extensive metastases with not much life expectancy. And we as permanent. And even if we have to remove that, we have the mountain to remove that. And this is a case of, do I have 1 minute? Excuse me, are the chairpersons here?
Yes, please. Yes, please go ahead.
Yes, you can finish fast.
Yeah, this is a case of arterial blowout of external iliac artery due to a retroperitoneal malignancy, sarcoma, and patient came with shock. We placed a covered stent and patient was stabilized. Many times, if the blowout is connected to communicating with the viscera or to the surface, chance of infection is there, but not in this case because it was just limited to retroperitoneal, but still chance of infection is there. But then we didn't have any other choice rather than do that. Next, into palliative procedures, the same case, the first case I showed you, the patient was advised to consult homeopathy, and the patient went for homeopathy and naturopathy treatment. And after 3 months, the patient came back with cholangitis, the catheter had blocked, and by the time a repeat CT showed extensive malignancy, and then in this case, we had to proceed. This you can see the distorted CBD and duodenum. You can see the catheter there. And in this case, we had to proceed with a metallic stent placement for palliation. And this is for these patients, a catheter, a vascular access is a very important thing. In this case, were asked to put a PICC line. There was central venous obstruction. We crossed that, dilated that, and closed the PICC line. And this is a very important, and eating through mouth, or at least reaching something in the intestines is very important for these people. In this case, I do advanced CA pancreas, inflamed duodenum. The gastroenterologists were not able to place the NJ tube. We were called, took a catheter, guide wire, put a strip wire across, and put an NJ tube there. So all these interventions actually very simple. Some interventions are very challenging, but they make a whole lot of difference in these patients, especially the palliative interventions, because more and more of these patients are having good life expectancy post good cancer treatment. Thank you so much.
Yeah. Hello. Yeah. Do we do the discussion now, or do we call up the next speaker now?
We will have a short discussion, sir. After that, we will go for a case-based discussion.
Okay, because even I have to leave, so you are there anyway. Case to manage the show, and Dr. Shiva is also here. So quickly about to Dr. Satyamurthy, what's your end point of ablation? On table, you develop 50% of the time a right ventral branch block. You haven't given the entire alcohol that you decided upon. Would you still go ahead?
No.
What is the end point? Suppose you do not get a gradient relief.
Whatever is that alcohol.
Or you get a gradient relief. Would you still inject the entire amount?
No.
What is the end point?
Whatever is the limit of alcohol, for example, for that patient, it is 2.2 ml. After reaching the 2.2, you should not go beyond.
No. I'm talking about stopping short. I'm talking about a right bundle branch block that's developed. No. At your first 0.5 ml, 1 ml you have given. No, would you continue to give the entire amount, or would you stop at that stage?
No, we don't stop. We have to continue.
Oh, okay.
The other way is true. After completing the stipulated amount, if the gradient doesn't come, may need a redo at a later date, at the end of 3 months, 6 months. So a lot of cases now, a lot of series are being published.
So you are not worried about the right bundle branch block that's happened, but you would yet come. Why wouldn't you come back even afterwards? Because we've seen our experiences that the gradient may have not dropped in a big way, but later on it still drops. We are always willing to get the patient back. rather than have a CHB on.
The literature
later on.
says unless you give the stipulated amount, you don't get the optimal result.
Absolutely. But if you get a right bundle branch block, that's what I'm asking.
Still we continue.
You
The
can still
RBP
go
is not-
ahead. Okay, that's a point well taken. You, of course, have a very large.
Not only that, even complete out block, we don't stop it.
Yeah, we'll go to the next chairperson, please. Dr. Shiba, you have a question of somebody else?
Yeah, I want to ask you, sir, suppose it leaks into the LED, what will you do immediately when you realize that the ethanol has leaked into the LED? What do you do? Number one. Number two, do you routinely use myocardial contrast echo prior to the procedure?
No, we don't use myocardial contrast because of the expense, not available in our country. We use the regular contrast, number one. Number two, fortunately, in none of our patients, it happened because we chosen such a patients where the septal is got adequate length to push the balloon and seal it or cork it properly. It never happened. But if it happens, patient develops an anti-valve MI. You should be prepared to treat the MI. You can't even give thrombolytic therapy because it's not a plaque rupture.
Yeah, one more thing.
And how do you treat it, sir?
Sorry.
How do you treat that MI?
Sorry, madam, I am unable to hear you.
How do you treat that MI due to seepage into the LED at that time on the table? You are supposed to.
Any other MI, like a spasm, Takotsubo also cause of severe spasm. So you have to treat it like any other MI, but you can't give lytic therapy here. It is not going to be helpful.
You can
there is a secondary thrombus.
Okay, you can do a PCI, right?
No, you can't do PCI because there is no plaque or there is no obstructive.
Okay.
You have to treat it as a Monica type, coronary spasm producing myocardial infarction. Spasm producing myocardial infarction.
Okay. Thank you, sir. Thank you.
Welcome.
Dr. Satyamurthy, sir, you had shown a case in which you have shown that in the immediate post-procedure, there was a definite reduction, but in the follow-up, there was a drastic reduction in the LVOT gradient. So in difficult cases, what will be your cutoff for the reduction in gradient to stop the procedure?
There's nothing like that. See, in all the patients, you won't get 100% reduction in the gradient. In majority, you will get. In some of the, if you see the strategy, it's about 2/3 to 75% of people have complete reduction of the gradient. In few people, it is suboptimal result. Suboptimal result from a severe outflow gradient, you are making it mild to moderate.
See, the reliance on myocardial contrast echocardiography is extremely important. We have had experiences where in a large magna septa, we've just targeted the medial branch and we just strictly go by the septal mitral contact point. And if you got a good depot happening there, then we would stop. We would not even do a bigger ablation, That's how it is. Yeah, so we need to start with the next speaker, I guess. Or I don't know, they have already put a screen share here for the next speaker. What is it?
Dr. Praful, can you hear me?
Yes, we can hear you very loud.
Sir, it's a pleasure to see you all. Unfortunately, there is some problem with the video, sir. So you are not seeing my picture. But I hope audio is fine.
Oh, okay.
Yes, sir. Yes, sir. Your audio is perfect.
Go ahead.
Sorry, I don't want to waste time by going into correcting the video. So as and when you tell me, then I will go into the talk.
Yes, sir. The next is a case-based discussion. Is a case of a cryptogenic stroke from the cardiologist perspective. We have Dr. Shivakumar from Madras Medical Mission, Chennai. Over to you, sir.
Thank you very much. It's a pleasure to join you all in this meeting. What is a cryptogenic stroke? A cryptogenic stroke is an ischemic stroke that is not attributable to cardioembolism, a large artery atherosclerosis, or a small artery disease, despite detailed cardiac, vascular, and serological evaluation. So it is something like a box of chocolate. You put in your hand inside, and you are not sure what you are going to get, whether you are going to get a perk, whether you are going to get a 5-star, whether you are going to get a dairy milk. Now, in practical perspective, about 1/4 of the strokes are considered to be cryptogenic stroke, and we need to redefine it as no probable etiology is determined despite a complete workup. For example, every stroke, if you do all 1,000 investigations, definitely you will achieve some sort of an etiology. But with a reasonable workup, you are not able to find a major cardioembolism, a major large vessel disease, or a major small vessel disease. Then that is called cryptogenic stroke. I'll tell you an example. A 14-year-old girl studying in 9th standard presents with sudden onset left hemiplegia. MRI shows a right capsular infarct. MR angiography shows normal proximal blood vessels. Echocardiogram was normal. An agitated saline contrast echocardiogram for PFO is negative. Clinical examination of heart and carotids are normal. ECG and Holter ECG is normal. She was started on aspirin and clopidogrel. 2 months later, she comes with aphasia and right facial palsy, the other side. MRI shows a new infarct in left frontotemporal cortex. A transesophageal echo for PFO was done, even though bubble test was negative. That was negative. A bubble contrast was repeated with agitated saline on transesophageal echo, and that was also negative. More extensive vascular workup was done, that was also negative. But this time she was started on aspirin plus warfarin to be a little bit more intense. Just 1 month later, right full hemiparesis, brief unconsciousness. MRI on a diffusion weighted image shows large right capsular infarct, which is a new infarct, and there are old infarcts as well. A repeat transesophageal echocardiogram was done once again with a strong suspicion that there will be a PFO. No PFO was seen. A repeat bubble study was done on Valsalva. Again, no right to left shunt was seen. So 3 admissions in NIMHANS Bangalore, no definite etiology. Now it gets diagnosed as mitochondrial disease, Melas syndrome, mitochondrial encephalopathy, lactic acidosis, stroke syndrome, and started on various B vitamins, other vitamin, coenzyme Q, lipoic acid, carnitine, and she is discharged on aspirin and clopidogrel with a guarded prognosis on recurrences. Now, since the patient's clinical story is repeatedly strokes, she gets readmitted in a cardiac unit in Bangalore, and this is the echocardiogram. Some minimal subtle pericardial effusion is found around the heart, and so the patient is referred back to NIMHANS to exclude tuberculous vasculitis. All the inflammatory markers are negative, ESR, C-reactive protein, quantiferon gold, many tests were negative, but still an empiric anti-tuberculous therapy was started. Within 15 days, she developed severe liver toxicity, and so the drugs were withdrawn. So now, this is a cryptogenic stroke. There are definite infarcts on cardiac MRI in different territories, no easily identifiable cardiac, vascular, or systemic cause. Recurrence is despite varying trials with antiplatelets and anticoagulation. Now, if you are giving her a diagnosis as mitochondrial disease, you don't know what you are dealing with. So it is perplexing. Mitochondrial disease, if you look at the treatment, coenzyme Q, antioxidant, riboflavin, folic acid, it doesn't give you the confidence that all these things are going to work and you are going to prevent a recurrence. So this is the cardiologist perspective. Yeah, disease where it looks like a cardiac embolus or repeated vascular infarcts, but you are getting a vague diagnosis. So clinical examination, when the patient came to us, normal clinical exam, normal pulses, carotids were normal, BP was normal in all the 4 limbs, heart sounds are normal, routine echocardiography, nothing is picked up. Now on a parasternal short axis, something was looking abnormal. This is the left atrium, and in the region of left atrial appendage, there seems to be a big sac. So it was pursued further, and we find that there was the left atrial appendage was looking much larger with to and fro flows from the left atrial appendage back into the left atrium. Now at this point of time, we have moved the cursor far to the left, almost beyond the mid-clavicular line. Now you move further towards the axilla, there is a large sac with layered thrombus. So we switched over to transesophageal echocardiography. Transesophageal echocardiography in the region of left atrial appendage shows a large sac with to and fro flows, and you are able to see a large sac here. Now you switch off the color, you find that there is a spontaneous echo contrast, sort of giant-like left atrial appendage with some thrombus here. It became very curious why this was not at all picked up on a routine echocardiography, and suddenly some findings are coming up. So we repeated an echocardiogram, but this time the echocardiographic probe is kept in the mid-axillary line. When you go to mid-axillary line with the patient in left lateral position, you identify 4-chamber view, and there is a 5th chamber, which is the hugely dilated left atrial appendage aneurysm with to and fro flows in and out. So now a CT scan is performed. Left atrium is giving off a left atrial appendage mouth, which is massive sac. The sac measures 11 centimeters. This yellow color is the left atrial appendage, which is larger than the cumulative size of LA and LV. A septal puncture was done. The patient is taken into the cath lab. A septal puncture is done, and the catheter is put into the left atrium, and the left atrial injection shows a large sac here. This is just a hand injection. Now, we decided to go and plug the mouth of this orifice because of 3 recent strokes all within the last 2 months. So she's not a candidate for an open heart bypass procedure on heparinization. Now, before entering into the sac, we need to protect the brain. So we put in 2 carotid filters. So this is a right filter and left filter. We don't know where is the mouth because we cannot blindly poke. So we do a rotational angiography with the catheter in the left atrium to identify in which projection we are able to profile the gap between the LA and the left atrial appendage. And that was RAO 40. So then in that position, we cannulated the RAO, the LA appendage, and we went in with a sheath, a 12 French sheath, and we put in a 24 millimeter post-MI VSD occluder device, post-myocardial infarction VSD occluder device. Orifice was 20 millimeter. So the doubts are adjacent structure should be protected. So one is the left circumflex artery. Left circumflex artery is not affected. The second is left upper pulmonary vein. Left upper pulmonary vein is also not affected. Of course, we confirmed by a transesophageal echocardiogram also about the left upper pulmonary vein. They were normal. This device was released. This is 1 month follow-up. The entire sac is thrombosed. This is 3-year follow-up. The thrombus-filled sac itself has got fibrosed and it is almost disappearing. No recurrences. Aspirin was withdrawn after 3 years. Now, summary. Cryptogenic stroke is a cerebral infarct with no easily identifiable cardiac, vascular, or systemic cause on a preliminary cursory examination, often managed with antiplatelets by neurologists, and accounts for almost 25% of all the strokes. For a cardiologist, an extremely aggressive pursuit for causes in such a scenario can show either it can be a paroxysmal atrial fibrillation with thrombus, it may be a tiny PFO which is not easily visible on a transesophageal echocardiography but is capable of shunting right to left, a mild, small, hidden pelvic or popliteal DVTs which keep coming to the right atrium to be embolized onto the left. It can be subtle ascending aortic atheromas or very, very rarely a giant left atrial aneurysm and some unusual conditions also. So from a cardiologist perspective, if there is a recurrent stroke in different vascular territory with very strong pursuit, we will be able to achieve a diagnosis. Thank you very much.
Thank you very much, sir. That was an exotic case indeed, and the topic is open for discussion. Sir, I will put a question, sir. Was the patient INR is in therapeutic range throughout the period of anticoagulation?
The first time the child presented, she was given aspirin and clopidogrel for 2 full months. On the 3rd month beginning, she developed a second stroke, and so she was started on aspirin plus warfarin, and the INR was maintained at around 2.5. Within 1 month of starting the aspirin and warfarin, a 3rd stroke happened, which was on adequate anticoagulation. But during this 3rd episode of stroke, she was also considered to be having this Melas disease, that is mitochondrial disease. And so the neurologist felt that since there was a recurrence on 2.6 INR, they will rather go back to aspirin and clopidogrel. And while the child was on this, the shift over from aspirin warfarin to aspirin clopidogrel, at the same time, a parallel investigation done at Jayadeva Institute showed that there is a minimal pericardial effusion. So a tuberculous vasculitis was diagnosed and she was started on ATT. Within 7 days, there was a bizarre liver toxicity. She went up, the bilirubin went up to 7, 8, and the enzymes got very much elevated. So warfarin was withdrawn completely, and she was switched over to clopidogrel in order to get some sort of stability. So there were 2 months of dual antiplatelet, 1 month of aspirin and warfarin in adequate dose. But having seen this 11 centimeter sac, I feel oral anticoagulation, even in therapeutic range, may not be good enough, because if the patient lies in a right lateral position, the clot may just gravitate down and it can pass on into the left atrium, because it was such a large sac. It was completely hidden behind the left atrium.
Satyamurthy sir, you were...
Yeah. Dr. Shivakumar, did you size it 1:1 or slightly oversize the device?
It was a 20 millimeter mouth, sir. We used a 24 millimeter post-MI VSD device. 4 millimeters more than that orifice.
Okay.
We did not think about a surgery because the patient had a stroke about 1 month ago. Going fully on heparinization may not be possible, so surgery was not considered, and we went in for a transcatheter closure. The fear about transcatheter closure is when we are manipulating wire and sheath inside, we can develop an embolus during the procedure, and so we put carotid filters. There was a thought process on how are we going to protect the vertebrals. There are some other devices, like for example Sentinel and all, which can be used to protect all the brain vessels. However, this child was small. She was a 14-year-old child weighing around 32 kilogram, and a 9 French sheath is needed for a Sentinel to protect all the 4 blood vessels. So we decided only to protect the carotid and take a chance on the vertebrals.
Sir, what do you think was the cause of the pericardial effusion? Is it as a part of the melas or a generalized inflammatory process?
Actually, there was no evidence of any inflammation. But what happened was the small amount of pericardial effusion, we really don't know what was the reason. Maybe I don't know whether we were picking a normal pericardial fluid which was getting redistributed more towards the right side because the left side sac was pressing against it. We never had any evidence of an inflammation at all. ESR, C-reactive protein, all were always normal. We did not do any investigation on that pericardial effusion part. Later, we did not find any effusion at all after closure.
What would have been the technical glitch in which the large sac was missed in the initial both transthoracic and transesophageals, because ultimately it proved out to be a very big sac. Sir, what would have been the technical glitch, sir?
Because actually, when we kept the probe in the left mid-axillary line and made the patient lie onto the left lateral position, we were able to get the sac. In the conventional apical 4-chamber view, when you keep the probe on the 5th space in the mid-clavicular line, it looks like a normal 4-chamber. But the sac sort of goes posteriorly and laterally. It was not at all getting visible. So, on a routine cardiac examination, we also did not find it. When the transesophageal showed it, then we got curious and we wanted to pick up, because it was massive. It was more than 10 centimeters. So then we kept on going lateral, and finally beyond the mid-axillary line, actually we picked up that sac. It was far more lateral.
Any more questions from the expert panel? If there are no more questions, if there are no more questions, thank you so much, Dr. Shivakumar sir, for a wonderful case. In fact, a life-saving for a young girl of this age with recurrent strokes. Thank you so much, chairpersons, expert panel, and speakers for making this session very interactive. Thank you so much.
Thank you.
We will begin the next session at exactly 2:30.